Good afternoon, everyone. Myself, Dr. Seema Thakur, on behalf of AOGD Genetics and Fetal Subcommittee, DGF Southwest, and DGF Dwarka, and Manipal Hospital Department of Fetal Medicine, I welcome you all to this webinar on case-based discussions in the fetal medicine. First of all, let me introduce to my co-chairpersons who have been the organizers. Himanshu. Next. So Dr. Sangeeta Gupta, who is a co-chairperson with me for the AOGD Fetal Medicine and Genetics Subcommittee, and she is currently working as a Director Professor, Ops and Gynae, Maulana Azad Medical College, New Delhi. The biggest credit which I feel is that she has been instrumental in establishing a fetal medicine clinic at MAMC and Lok Nayak Hospital, and she has been probably the role model for all the government hospitals. And she has been awarded Commonwealth Scholarship in 2007 and trained in fetal medicine at St. George's Hospital, London, which anybody would dream of, for getting trained. I would also like to introduce the co-chair, the secretary, DGF Southwest, Dr. Shashi Lata Kabra Maheshwari, and she is currently working as a senior specialist of Gynae, EDU Hospital. And the biggest credit which I can see, she has organized more than 50 workshops on the postpartum hemorrhage, and hats off to Dr. Shashi Lata that she is quite devotionally and passionately working on this area, which is very much required. Dr. Leena is, and she is co-chairperson DGF Medical Legal Cell. Next slide. She is executive member of Multidisciplinary Committee AOGD, and she is currently attached to the Manipal Hospital Dwarka as senior consultant of Gynae. So I welcome you all, and also the co-organizing chairperson, Dr. and Dr. Geetanjali, which we'll be discussing when they have the presentations. So now I invite the Dr. Achla Batra ma'am, the president of AOGD, to address the gathering.
Thank you, Seema. I think like we
Dr.
were...
Achla Batra is the president of AOGD.
That's fine. Yeah.
And she is currently working as a professor.
Seema, I think that's enough. Yeah, thank you, Seema. So I think this case-based discussions are a very integral and important. So, am I audible?
Thank you.
Am I audible?
Yes, ma'am.
Okay, thank you, Seema. I welcome everybody to this wonderful webinar on case-based discussion on fetal medicines. I think it's a very good idea, Seema and Sangeeta, to have a case-based discussion. We might talk a lot of theory, but when it comes to actually handling a case, the theory doesn't really help so much unless you have thrashed out the cases, and it really gives a very clear insight to what you need to do. So during the course of the year, you have really done very good webinars in fetal medicine, and all these topics have been discussed, in theory, and today you've taken them as case discussions. I think there's going to be a real help on case discussion on Hydrops and thalassemia. And you also called Crusader for Thalassemia, Mrs. Shobha Tulli, who's done so much of work. Welcome, Mrs. Shobha Tulli. Welcome to our platform, and we are really happy and honored to have you with us. And you have also, a lot of stalwarts of fetal medicine are there, so it's going to be really beneficial to people. I can see Vandana Chadda, Sangeeta Gupta, Smita Mishra, Bhavna, and Vandana Chadda. So wish a great success to this webinar, and thank you.
Now, I would like to welcome our chief guest, Dr. Smita Rathore. She doesn't need any introduction to this gathering, but for the sake of introduction, She is currently Director, Professor and HOD at Maulana Azad Medical College, New Delhi. Slide please, Himanshu. Her area of interest is maternal fetal medicine,
I think it's all right, Dr.
vaginal
Sima,
surgery.
move ahead
And
with
she is a
scientific
program coordinator for DNB and maternal fetal medicine. She has got more than 50 publications in index journal, and she's a joint editor of 4 books and more than 25 chapters in the books. She has been investigator for many national. So, ma'am, we would like you to,
Dr. Sima, it's enough.
say a few words about this meeting.
At the outset, thank you so
Ashmita
much,
ma'am,
Dr. Sima, Dr.
would
Sangeeta,
like
for
you
inviting me
to
for this webinar. I think Fetal Medicine Committee has been doing a great work over a year in this particular area and educating and updating the knowledge of general obstetricians regarding fetal medicine. Fetal medicine and genetics is expanding its span very, very rapidly, and it's very important that we update ourselves on this area. The today's scientific program is very well designed, covering the common problems like thalassemia, and have experts and stalwarts on the panel. So I'm sure it's going to be beneficial to all of us. And thank you so much for the invite, Dr. Sima. Thank you so much. Over to you, Dr. Sima.
Thank you, ma'am. Yeah, so I would like to welcome who is the expert for the session today, and she also doesn't need any introduction. Currently, she is working as the head of the Satwa Fetal Medicine Center in Delhi. So now everybody is waiting for the Mrs. Shobha Tuli, and we would like to hear from Mrs. Shobha Tuli, who has been the president for India Thalassemics. So we welcome you, ma'am, and we request you to, so Mrs. Shobha Tuli is one of the founder members of the Thalassemic India, which was established in 1987 in New Delhi. And from 1993 onward, she has been holding the post of the Secretary of Thalassemics India. She is working closely with the Thalassemia International Federation, Cyprus, since 1992. And currently she is holding the post of the Vice President. In
That's enough. That's enough.
The one thing which I wanted to tell that she has been instrumental in establishing the Thalassemia unit way back in 1993, and the ward is still exists there by the same name, Preeti Tuli Thalassemia unit. And I was fortunate to work at this Preeti Tuli Thalassemia unit at Sir Gangaram Hospital. So we welcome you, ma'am, and we want you to say a few words about what you faced and how to
Good afternoon to everyone. There are so many names here, so many experts, doctors, and the stalwarts that I will not get enough time to name each one of you. So good afternoon to you, and I feel honored that I am being invited to take part in today's webinar. Thanks to Dr. Achla Patra and her team members. Thalassemia is very close to my heart. In the next few minutes, I will take you back, my memories of 70s and 80s when nothing was in place as far as thalassemia treatment is concerned. The blood was the biggest challenge. There was no NGO in our country. So Thalassemics India, a few parents got together. In 1987, we formed Thalassemics India. And this is a parent and a patient body. And during this journey of over 35 years, when we started our journey, we had nothing in place, no support from the doctors, no support from the hospital, no support from the blood banks. And the biggest challenge at that point of time was how to get blood for our children, because this was very important that they need blood for their survival, as you all know. So that was the biggest challenge. And another was the medicines were not available in our country. I remember that I used to travel to London to get some medicines for my daughter as well as some other parents. So when we formed an NGO, we tried that, well, there has to be thalassemia centers, number one. We have to get associated with some Red Cross or the hospitals to arrange blood for them. And we have to involve the doctors, because doctors' involvement is very, very important. If they do not stand with us, our battle is never won. And then was, of course, to draw the attention of the government. Even if whatever resources you are able to gather, if you don't have the support from the government in order to get the provisions or some benefits, on the tax exemptions and all that, our battle could never be won. So during this journey of 35 years, we tried our best not only to overcome such challenges, but also to make sure that in other states, other cities also, there are NGOs formed. So we played a very important role in establishing thalassemia NGOs in the other parts of the country. Today, where we stand in 2022, I would say that, well, we managed to get the support of the medical fraternity, whether it is a gynecologist, obstetrician to a certain extent, but of course, from all the blood banks and the hospitals, they stand with us hand in hand, and also to draw the attention of the government, which is very, very important. The place from where we work today is our office given to us by the Ministry of Health and Red Cross. We are working in association with Ministry of Health Family Welfare for a Coal India project, where thalassemics, when it comes to bone marrow transplant, which is the only cure, our society is being nominated by the ministry, and we are working hand in hand with them. When it comes to the disability issue, we have won half of our battle, and we are working with the Delhi government on that. We are a part of with the Delhi government and all. And apart from that, what we got a drug license, because availability of drugs in some states is very, very difficult. And these companies, MRI price is very, very high. So what we did was we got a drug license, and we managed to send drugs and equipments to all over the country by couriers or by hand, whatever as per their requirement, and at a very subsidized price. Because you will understand, when it comes to the thalassemia care and management, most important is the blood, then comes with their treatment, So we as an NGO have tried, and also get involvement of the corporates. That's how we got the under CSR. They're funding our activities, and we nearly give help free of cost to nearly last year, in 2021, we helped 400 patients by giving them free of cost medicines, at that amounted us to nearly 44 lakh of rupee in a year. But when it comes to awareness and prevention, and my humble appeal to all of you at this point of time is, whatever we may do, we cannot succeed, like I said earlier, if we don't get the support from the doctors. When it comes to the gynecologists and obstetricians, ma'am, as you know, I'm a thalassemia mother also, as you have said, in your initial introduction for me. So you can understand my pain and what I have gone through since 1970s. I still stand straight, and I am into this thalassemia work for till God will allow me, till my health allows. But what is the biggest challenge, and what we need support today? Talking in between all the well-known gynecologists of our country is that, well, thalassemia should be included as one of the tests when a pregnant woman come to you, whether it is a private hospital, whether it is a government. Collectively, we have to now make it that, well, we have to make Delhi thalassemia free. So which, if AOGD stands with us and AOGD is in front, we need your support. It has to be made, it is only CBC test has to be written there, which I'm sure you already do. But it is only when the CBC is done, one has to read it, whether it has to go for HPLC or no. So my humble request, with folded hands, as a mother, thalassemia mother, and as part of Thalassemics India, as part of TIF, as part of the Federation of Indian Thalassemics, that please let us know that how together we can move forward and, make sure that to avoid the birth of future children with thalassemia major. That will be a biggest help coming from your side. With these words, I would like to thank Dr. Achla Batra and all the team members, Dr. Seema Thakur and all the other doctors who are here, and let us know, you also can guide us that how together we can work on a project to make sure that we achieve, what is required, and that is a zero births of children with thalassemia in our city of Delhi and of course in the country at large. Thank you very much, ma'am. You are muted. Sorry, I can't hear you.
Yes, so thank you, ma'am. So this is really motivational, and I agree that the drive to prevent thalassemia. Actually, we have started working universal screening for thalassemia during pregnancy, and probably people like you, when they can join, sometimes the women are not that capable. Probably we can contact you so that you can help them for the prenatal diagnosis. Definitely, this is the need of the hour, because the Delhi population and North India population, 5 to 10% is the carrier rate incidence. This is very, very high. So probably we need to work harder so that to make, like Cyprus, zero thalassemia. You have been in touch with Cyprus. So these people, they made thalassemia incidence zero. And if they can make it, though this is a small country, but why can't we? We are a big country, but we have many more hands compared to them, many more resources. So probably we can also work towards the zero thalassemia. And I assure you that we will support you in all ways wherever you want us. So with this, we now move on to the academic sessions for today. And the main attractions for today is the thalassemia and the Hydrops fetalis. Thalassemia, as you know, this is a disorder of ineffective erythropoiesis, and the incidence of the major thalassemia is about 1 in 4,000. And for the survival, the children would depend upon the regular blood transfusion, and this is also not sufficient. They would require the regular, the iron chelation therapy. So the life is a big burden. So the prevention is the only source to, manage this condition as far as our country or any other country is concerned. And the second, the major attraction today is the Hydrops fetalis. The topic, which is very common, like, we can say 1 in 2,000, but we don't get that much academic discussions on this, because we think that, most of the Hydrops fetalis is the, 80 to 90% that is, fatal only. So the chances are the poor prognosis. So we don't work much, but today's CME will guide us how to, investigate these mothers, and how to, if many of them would be treatable, so how to treat that also. So now I request Dr. Leena to introduce the chairpersons for the first session.
Yeah, thank you very much, Dr. Seema. That I think Ms. Shobha's talk was really wonderful. We were mesmerized, and
Yes.
It's always wonderful, to be with the fetal medicine fraternity. And I think this talk is wonderful. So let's start with the very first session. I call upon the chairpersons for this session, Dr. Shilpa Ghosh. Dr. Shilpa is the director of Obs-Gynae at the Akash Healthcare in Dwarka. She's done a senior residency from LHMC and has more than 20 years of experience. She was previously associated with the Fortis Vasant Kunj, Columbia Asia and Venkateshwar Hospital, and has a special interest in high-risk pregnancy. Our next chairperson is Dr. Madhulika Sinha. Dr. Madhulika Sinha is a senior consultant and the unit head in Obs-Gynae at Akash Health Center, a super specialty hospital. She's a life member of the FOXI and IMA and an alumni of the Institute of Medical Sciences, BHU. She has a number of awards and achievements to her credit. She has a special interest in infertility and high-risk pregnancy. Our next chairperson, Dr. Dipti Yadav. Dr. Dipti is currently as a senior consultant and a unit head at the Venkateshwar Hospital. She's trained in minimal invasive gynecology, and she's had a certificate in advanced infertility management. So she's also here with us. Our next chairperson, Dr. Bharti Seth. Dr. Bharti is the director of the Bharti Nursing Home in Dwarka. She's a visiting consultant at all the leading hospitals in Dwarka. She has been the co-chairperson of the Gynae Forum of IMA in Dwarka, and also the former senior vice president of this forum. She is also here with us. Now I call upon Dr. Madhulika Sinha to please introduce the speaker. Dr. Shilpa is there? Dr. Shilpa? Is she there with us?
If they are not there, I think Dr. Deepthi is there. Okay, so I think I can introduce Dr. Gitanjali. Okay, CV, please. So I feel pleasure in introducing Dr. Gitanjali Bahal, and with whom I have been interacting in so many occasions. And she is currently working as a fetal medicine consultant at Manipal Hospital. She has done her fellowship in fetal medicine from Mediscan Chennai, and she has also done fellowship in clinical genetics from SGPGI Lucknow, and she has worked formerly at Fernandez Hospital, Hyderabad, and her main area of interest is the fetal echocardiography, fetal therapy, first trimester fetal anomaly scan, and multiple pregnancy. So I welcome you, Dr. Gitanjali.
Thank you, ma'am.
Now the stage is all yours.
Yeah, ma'am. Thank you, ma'am. Is my
So Dr. Gitanjali and Dr. Bhavna. Go ahead. You are organizer also. That's what I wanted to tell. Yeah. So.
Thank you, ma'am. So my today's, first of all, welcome you all and good afternoon. So my today's talk is approach to screening and prenatal diagnosis of thalassemia major. So my point of discussion will be hemoglobinopathies and its classification, incidence and burden on society, beta thalassemia carrier screening protocol, how to detect.
Yeah, Dr. Gitanjali, we can't see your slides.
Okay, I have, okay.
2 बार करना पड़ता है.
Okay.
2 बार करो, फिर नीचे से खुला हुआ होना चाहिए वो.
इसमें तो shared. I have to go back, stop share and again restart.
नहीं, आपने शेयर किया, एक स्क्रीन आई, फिर नीचे में देखिए ग्रीन होगा शेयर.
Yeah, again.
Right side of your hand, on your right side, एक शेयर ऊपर होता है, फिर एक नीचे. नहीं, फिर उसके बाद ना अब आपने जहाँ खोला हुआ है ना अपना, उसको आप खोलिए, पावर पॉइंट को आप खोलिए.
खोल लिया मैंने.
पावर पॉइंट खुला आपका?
हाँ, खुला ना.
नहीं आ रहा है, I think.
Just a minute, I am calling my IT person.
Ma'am.
Yeah.
When you start share screening, you can see stop share.
Yes. So my point of discussion will be hemoglobinopathies and its classification, incidence and burden on society, beta thalassemia carrier screening protocol, how to detect alpha thalassemia carrier, aim of genetic counseling, condition require prenatal testing, genetic test for thalassemia, and take home message. I'm not able to move my slides.
Ma'am, click on the slide. Ma'am, click on the slide once. Yes.
Okay.
Okay.
So, sorry. So, first of all, what is hemoglobinopathies? These are inherited disorder of globin, and we can classify this into 2 groups. The first one is mutation in the gene coding for the globin protein, which can alter the protein output. When the protein output decreases, it is called as thalassemia, and which type of globin chain is affected. According to that, we can classify it into alpha thalassemia and beta thalassemia. One more entity is there in which there is, instead of decrease in the protein output, there is increase in the protein output. This is known as hereditary persistence of fetal hemoglobin. The second group is mutation in the globin gene, which leads to abnormal structural protein, which is called as variant hemoglobin. When this variation happens in the beta cluster type of gene, the examples are HBS, HBE, HBC. And when this variation happens in the alpha type of globin, then this is the example is hemoglobin constant spring. So why hemoglobinopathies are important? Because these are the most common single gene disorder, and almost 270 million carrier of hemoglobinopathies are present worldwide. And out of that, 80 million carrier are alone, thalassemia alone. So when we talk about our country, the burden of beta thalassemia is, in our country, almost 45 million carrier of beta thalassemia. They constitute around 3 to 4% of total population is present in India. And the incidence of hemoglobinopathies, which mainly constitute thalassemia and sickle cell disease, is around 1.2 per 1,000 live birth. And almost 12,000 to 15,000 infant of thalassemia major born per year in our country, which contribute 10% of the thalassemia born in the world. So this is one of the common cause for requirement of blood transfusion. So now these data suggest that how big is this problem. So for this, there is one day dedicated for World Thalassemia because of the huge problem. But we should aware that every day we should practice so that we can prevent this problem. So why beta thalassemia carrier screening is required? So as we know, this is an autosomal recessive condition. When both the partner, they are carrier of beta thalassemia, there are 25% chances that baby will be normal. And in 50% chances, the baby can be carrier like parents. But in 25% chances, there are that baby can be affected with thalassemia major. So we want to prevent this condition. Normally, autosomal recessive condition, they are more common in consanguineous couple. But because we know that this is a high prevalent condition, almost 3 to 4% carrier status is there in our population. So even non-consanguineous couple also can manifest this problem. So for this, there is a stepwise approach is required for beta thalassemia carrier screening, and it includes universal screening in the early pregnancy or periconceptional period. Second, we should know when to screen the partner. The third is when to refer for genetic counseling and whom to offer the prenatal testing. So first step is universal screening in early pregnancy or periconceptional period. And we should advise them along with the other routine blood investigation, HPLC should be advised. So one may argue that we can do, because we are doing complete blood count and peripheral smear, so we can see that whether there is microcytic hypochromic type of anemia is there or not. And in those cases only we can offer a hemoglobin electrophoresis or HPLC. So in this approach, we can miss a large number of carrier status, because sometimes whenever there is coexistent vitamin B12 or folic acid deficiency is there, or sickle type of disease or TRAT is there. So in that case, peripheral smear will be normocytic normochromic type. So we can miss the carrier status. So this is a slide which is showing how we can differentiate between the thalassemia and iron deficiency anemia. So we know that red cell distribution width will be increased in the iron deficiency anemia, and iron indices will be abnormal. So to show the importance of HPLC, I want to discuss this case which we got last year. Mrs. X, 32 years old, Rh positive, non-consanguineous couple, second gravida para 1 live 1. Previous cesarean was done in view of non-progress of labor. She delivered a male child, 3.2 kilogram of birth weight, and her antenatal period was uneventful in that pregnancy, and baby was diagnosed as thalassemia major at the age of 10 months. So bone marrow transplantation was done in that child, and presently he is doing well. So now she was pregnant, and she came to us at 6 weeks of pregnancy, and definitely the couple was anxious. So we have decided this management protocol, as the index case was already diagnosed case of thalassemia major. Mutation study of index case was available, and both parents, HPLC was done after the diagnosis of thalassemia in first child, which suggests the carrier status. So mutation study was not done. So mutation study of both the parents was advised, and we have planned for prenatal testing at 12 to 13 weeks. So CVS was done, which was suggestive of carrier status in the fetus. Decided to continue the pregnancy as the fetus was carrier-like parents, and antenatal follow-up was done and delivered a male baby at 38 weeks by cesarean. So this is the report of the mutation analysis. We can see this was the mutation, same mutation which was present in the index case as well as the parents. And this was heterozygous, means suggestive of carrier status. So we can see that if HPLC would have done at a proper time, we can prevent the birth of a baby who is affected with thalassemia major. And this baby was lucky, but every child who is born with the thalassemia major may not be that much lucky. So what is high performance liquid chromatography? It is a technique to separate different hemoglobin components according to their charges, size, and affinity. So it is basically used to diagnose hemoglobin disorders, and this is the chromogram, which is suggestive of that there is various peak which denote various type of hemoglobin component. And for interpretation of the beta thalassemia, we usually observe how is the concentration of HbA2 and F. So in thalassemia minor, HbA2 is usually elevated than normal, and in thalassemia major, mainly HbF is increased. And to be on safer, so HbA2 usually remain less than 3.5%, but it can increase from 4 to 11% in the cases of thalassemia minor. So to be on safer side with borderline HbA2 level, always check for partner HPLC. For example, if the value is coming in between 3 to 3.5, always offer partner HPLC. So we can, by using this approach, we can detect additional carrier status. One more important thing is several hemoglobin variant, they elute same window. They provisionally diagnosed by the retention time and area percent. For example, this is a report, HPLC report, in which we can see hemoglobin adult is showing 60.9%, definitely reduced, and HbA2 is increased 33.5. So we know that in thalassemia, it cannot be beta thalassemia trait, because in thalassemia trait, elevation is usually in between 4 to 11%. So because the HbE share the same window, they elute on the same window. So here the possibility is that this is because of the heterozygous status of HbE. So always advise partner HPLC here. And in this case, we have advised partner HPLC, and it was also carrier for HbE. And the couple was from West Bengal. So we know that HbE is more common in the northeast area and the West Bengal area. So now we should know that what is the normal composition of various types of hemoglobin at birth and from 6 months of age. So we can see here at birth, still fetal hemoglobin is the major contributory hemoglobin, which contribute around 70 to 80%, and it is made up of alpha 2, gamma 2 globin chain, while HbA constitute only 10 to 30%, and it is made up of alpha 2 and beta 2 globin chain. So this is the reason why newborn screening is not good for detection of the carrier status. We are not able to see the carrier status at this point of time. However, we can have the suspicion for thalassemia major if the concentration of the hemoglobin is HbA is less than 20%. So this is the reason why newborn screening for thalassemia carrier is ineffective. From 6 months of age, there is switch over of HbF from HbF to HbA, and now HbA is contribute around 95%. Small percentage is HbA2, which is made up of alpha 2 delta 2, and hemoglobin F is very less than 2%. So now, because from 6 months of age HbA takes part, so this is a reason why mutation affecting the adult HBB gene like beta thal and sickle cell disease usually manifest at this stage after 6 months of age. Similarly, like in our case. So this is a HPLC, which is showing beta thalassemia, various type of beta thalassemia, trait, intermediate, and major. So in trait, we should know that HbA2 usually get elevated more than 3.8%, while in intermediate, there is reduction of the HbA, and this reduction actually depends on the severity, and it ranges in between 10 to 30%, while HbF increases from 70 to 90%. In thalassemia major, HbA is usually totally absent, and HbF is the major contributory hemoglobin, 90 to 95%. So the question is why HbA2 is increased in thalassemia minor but not in major. The reason is we know that beta globin chain has more affinity for binding the alpha chain in comparison to delta chain. So because of the relative lack of the beta globin chain, delta chain has the opportunity to incorporate with alpha chain for hemoglobin synthesis, and this is the reason why HbA2 is increased in thalassemia minor. But what happens in thalassemia major? Because here there is a gross deficiency of HbA. HbA is totally absent. So what happens? Because of absence of beta globin chain, there is excess of alpha chain which get accumulated in the RBC and causes RBC degradation and hemolysis. So because of this, there is stimulation for increase in the erythropoietin level, and this erythropoietin level will cause bone marrow expansion and increase in the F cell production. And because of the ineffective erythropoiesis, this F cell, activated F cell, remain persistent. So these F cell are responsible for increase in the HbF. And when we will give repeated blood transfusion, there will be decrease in the erythropoietin level. This is the reason why in repeatedly transfused patient, HbF level will be changed. So now the next question is, are there any type of thalassemia, beta thalassemia, in which we can get normal type of HbA2? Definitely the answer is yes, because whenever there is coexistent beta delta thalassemia, which occurs due to deletion of the HBB and HB delta gene simultaneously, in these cases, we may not get elevation of the HbA2. In heterozygous form of beta delta thalassemia, HbA2 will be normal. So then how we will interpret this condition? Because in HPLC, there will be increase in the HbF. While in homozygous form, HbA and HbA2 will be absent, totally absent. The second condition is whenever there is coexistent severe iron deficiency, that actually mainly create effect on the alpha chain. It will cause the reduction in the alpha chain, as well as it will decrease the transcription and translation of the delta chain. So this is the reason why in severe iron deficiency along with the beta thalassemia, we may not get the elevation of HbA2 to the certain extent. So now the condition in which HbA2 is raised but thalassemia is not there. So yeah, the conditions in which there is delayed nuclear maturation of RBC precursors like megaloblastic anemia, sometimes in sickle cell anemia or unstable type of hemoglobinopathies, in severe hyperthyroidism and patient on antiretroviral therapy, we may get raised HbA2. This is the reason why whenever we are making the diagnosis, then always see all the investigation and then make the diagnosis. So condition in which there is HbF can be increased. The one condition is that is physiological when the baby is less than 6 months of age. The other condition, as we know, beta thalassemia major and delta beta thalassemia, as we already discussed. Another condition is hereditary persistence of fetal hemoglobin. Here fetal hemoglobin will be increased. So this is very important to differentiate these HPFH to beta thalassemia major and delta beta thalassemia, because this is a totally benign condition and it can also raise in aplastic anemia and juvenile form of CML. So these are the various type of hemoglobinopathies and different combination of thalassemia which are present in our population. But the most important thing is we should be aware that HBE, this variant hemoglobin, is more common in the Northeast and West Bengal area, while HBD Punjab, as the name is suggesting, it is more common in the Punjab area. So the next question is how to detect alpha thalassemia carrier. So basically it is not straightforward like beta thalassemia. It is diagnosis of exclusion. So whenever for example, if the patient is having microcytic hypochromic anemia and iron deficiency is excluded, HPLC report is also normal, then always have the suspicion that patient may have alpha thalassemia carrier status. Then the question is why HPLC remains normal in this condition? Because whenever there is alpha thalassemia carrier, means alpha chain is less than the beta chain. But these excess HBB chain are not in that much abundance. Second, the particulate, that HBH inclusion, they are very unstable. So this is a reason why in routine HPLC, we may not get the clue from the routine HPLC. So for these cases, there is a need for spatial gel electrophoresis and supravital staining technique like brilliant crescile blue. So on hemoglobin electrophoresis, there will be elution peak detected by the visual analysis characterized by the sharp peak in the first minute of elution. Because after that, HBH will, because I have already told you, HBH is very unstable, so we may not get that thing. So these are the various types of alpha thalassemia. We, 4 types. Silent carrier means one alpha chain is absent. Minor means 2 alpha chain is absent. But this is very, very important now. Whether it is trans type means 2 alpha on different site absent, or cis type, because cis type of carrier, if they marry to a partner who is also cis type of alpha thalassemia carrier, then it will lead, there are chances, 25% chance of severe disease like Hydrops fetalis. But luckily in our country, we are having more trans type of alpha thalassemia carrier instead of cis, which is more common in the China and Malaysia, Thailand countries. The third is HBH disease, where 3 alpha are absent, alpha chains are absent, and Hydrops fetalis, where alpha is totally absent. So now the thing which we should keep in our mind, because alpha is participant in the fetal hemoglobin. This is the reason why alpha, severe type of alpha thalassemia can manifest in utero, while it is not true for beta thalassemia, because beta globin chain is not contributory in the fetal hemoglobin. This is the reason why beta thalassemia cannot manifest in utero. Now, the importance of hematological examination, I want to show, tell you by this case, although this is not a prenatal case, and I am thankful for this case. I am thankful to Dr. Seema for this case. So this is an index case which presented at 5 months of age, which was male baby with a complaint of delayed milestones because there was no neck holding, and there was history of delayed cry at the time of birth. Birth weight was 1.88 kg, and all the antenatal ultrasound was suggestive of IUGR. On examination, there was subtle dysmorphism, severe hypotonia, wrist reflexes, and hepatosplenomegaly. Metabolic screening was normal. Ophthalmic evaluation and EEG was also normal. MRI brain was suggestive of periventricular leukomalacia. So no obvious genetic cause was identified at that period of time, and baby was re-evaluated at 5 years of age, and there was severe microcephaly and hypotonia. But twist occur when younger brother of the index case again presented with a similar complaint at the age of 7.5 months with delayed milestone, microcephaly, severe hypotonia, similar facial dysmorphism. So MRI brain was suggestive of thin corpus callosum, dilated ventricular system, and periventricular leukomalacia. Metabolic screening was normal. So blood investigation was done, and it gives a remarkable clue. How? Because the CBC was suggestive of microcytic hypochromic anemia. Peripheral smear was showing microcytosis and isocytosis and teardrop cell, which is a feature of thalassemia. But iron indices was normal. HPLC for hemoglobin was normal, and because of above finding, suspicion of alpha thalassemia was made. So spatial hemoglobin electrophoresis and brilliant crescile blue staining was done. And this was the picture which was showing hemoglobin electrophoresis. Here we can see 3 bands. One strong band is of HbA. The weak band, faint band is HbA2, and fast moving band was of HbH. And similarly in peripheral blood smear, staining of the red cell using brilliant crescile blue was showing inclusion, HbH inclusion in the peripheral smear. So diagnosis of alpha thalassemia was made. And because of presence of alpha thalassemia, both babies were male and mental retardation was also there. So diagnosis of ATRX was suspected in this case and genetic evaluation was started. So first deletion and duplication analysis of alpha thalassemia was done for both the babies by using MLPA, but it was negative for both the brothers. So ATRX gene analysis was done in younger child and it was suggestive of a hemizygous substitution in exon 31C, which was a gene for ATRX. So same mutation was present in the elder brother as well as mother was a carrier for same mutation. But mother was normal, so X inactivation study was done in mother, which showed that she had skewed X inactivation. So the reason of alpha thalassemia in case was there was no deletion. Alpha gene was completely normal, but the problem was because ATRX gene is involved in the regulation of the alpha gene expression. So because of mutation in the ATRX gene, there was suppression of the alpha thalassemia expression. So this is the case and this is the pedigree. So hematological examination. So this is a reason why all the investigations are important and sometimes it can give a great clue to diagnose a very rare genetic disorder. So the second step after the diagnosis of carrier status in the female, so we should know when to screen the partner. So whenever HPLC report of the pregnant female is showing beta thalassemia carrier or any variant hemoglobin like HBS, HBD, HBE, always refer them to, so always advise the partner screening. And if both partner has same or different type of hemoglobin variant in their HPLC report, refer them to for the genetic counseling. So what is the aim of genetic counseling? It is first to confirm the molecular diagnosis, to recognize the need for prenatal testing, to differentiate that between whether this will be clinically silent disease or significant symptomatic disease. 3-generation pedigree analysis is must in genetic counseling, and to assess the risk for thalassemia or hemoglobinopathies in other family members. The next step is whom to offer for prenatal testing. So this is a long list in which whenever both partner carrier for beta thalassemia or one partner is carrier for beta thalassemia and other is having variant hemoglobin like E or S, if both partner are carrier for sickle cell trait, if one partner is carrier for sickle cell trait and other is having beta thalassemia or E or D, Punjab, if both couple they are having hemoglobin Lepore carrier or one beta thal carrier plus hemoglobin Lepore carrier, and particularly alpha thalassemia when both the partner are carrier cis type of carrier. So it is very, very important. So I will just show you some cases. This case is second gravida para 1 live 1, 18 weeks pregnancy. Previous baby was affected with E beta thalassemia and first child which was affected with E beta thalassemia, his hemoglobin was 7 to 8 mg%, but not on transfusion dependent. So this is the HPLC report, which is showing for wife, there was HbA2, means HbE 26.9, husband 4.9. So that means carrier, beta thal carrier. And index child was showing HbA2 68.6 and 24.6 HbF. So that means it was BE beta thalassemia. So whenever one partner is carrier for hemoglobin E and other partner is for beta thalassemia, there are 25% chance of affection of the baby with hemoglobin E trait beta thalassemia. So the problem is because E beta thalassemia, they clinically behave like beta thalassemia major or intermediate, but we don't know which one will behave like intermediate or major, and they may be symptomatic in early stage, may or may not be transfusion dependent. So it is very important to advise them to go for prenatal testing. So in this case, CVS was done and fetus was beta thalassemia carrier. So they have continued the pregnancy. The next case is priming gravida, Rh positive, non-consanguineous couple, IVF conception. So they came at 10 weeks of pregnancy with HPLC report, which was suggestive of HbA2 for in the wife is 36% and husband 27.9%. So definitely both were carrier for the HbE. So the next step was molecular testing for HbE. So both husband and wife were heterozygous for HbE codon 26GA mutation. So in this case, we didn't advise prenatal testing. The reason was, this is a picture of homozygous, because we know, because both the partner, they are carrier for HBE. So now 25% chance of HBE, homozygous type of HBE disease. So we can see this is a blood picture of homozygous HBE. Hemoglobin is quite fine, 14.5. HbA is very less, 3.9, but major contributory protein is here, globin protein is HbA2, hemoglobin is HbA2, that is 83.8%. So because this homozygous HbE is clinically silent or mild anemia, so there is no requirement of prenatal testing, and assurance was given to the couple. So now next case is Mrs. X, 26 years old, primigravida, non-consanguineous couple. HPLC report of wife is suggestive of beta thalassemia carrier status because HbA2 is 4.6%. Here another variant hemoglobin, that was HBD, was present, 38.3%. So now we know that one partner is carrier for HBD, one is carrier for beta thal. So there are 25% chance of baby affected with beta thal D carrier, D disease. But because this disease will not create any serious disease to the offspring, so there is no role of PND, and assurance to the couple given, as this combination cannot cause an inherited severe anemia in their child. The next case is primigravida, Rh positive, couple from Africa. And HPLC report was showing sickle cell trait for both the partner. But they presented at the gestation of 26 plus 5 weeks. Mutation analysis was suggestive of sickle cell mutation. Amniocentesis was done in this case, and fetus was homozygous for HBS mutation. And after that, couple lost the follow-up. Now, this is actually a very important example that we should advise HPLC in early pregnancy at booking visit. So optimal time is, HPLC should be advised in pregnancy, but at optimal time, because otherwise we may not be able to act upon the result. As both the partner, if they are carrier for HBS, there are 25% chances of having the baby with sickle cell disease. So now a few words about the genetics of beta thalassemia. Beta globin, actually this is encoded by a structure which is known, a structural gene which is known as HBB gene, present on the short arm of the chromosome 11. So this is beta globin gene cluster. And in this we can see that distribution from 5' to 3' end is from embryonic to fetal and then adult type. So this is evolving type distribution is there. Similarly, alpha globin cluster, they are present on the chromosome 16, and again from 5' to 3', it is actually distributed in evolutionary phase, like zeta 2, zeta 1, which is involved in the embryonic hemoglobin, and alpha 2, alpha 1, which is a part of fetal as well as the adult hemoglobin. So this is a structure of hemoglobin. We know this is protoporphyrin ring, and here we are having 2 alpha and 2 beta globin chain. For the regulation of the alpha globin, there are 4 alpha gene available for a pair of chromosome. While for regulation of the beta globin, there are 2 gene, they are available for a pair of chromosomes. So even though there is double number of genes present for regulation of the alpha, the ratio between the alpha and the non-alpha protein is always remain 1. Whenever there is imbalance, it will create problem. So beta thalassemia mutation, actually they are heterogeneous at the molecular level. More than 350 beta thalassemia mutations are identified, and we can divide them into 2 groups. The one is non-deletion type of group, which is point mutation, that is most common, while in alpha thalassemia, they are deletion type of mutation are more common in alpha thalassemia. So non-deletion beta thalassemia, deletion type of beta thalassemia, which is very rare. So non-deletion beta thalassemias, these are point mutation. Single means single nucleotide substitution or oligonucleotide insertion or deletion that affect the beta gene expression through various mechanisms. So this non-deletion type of beta thalassemia also, they can affect at different level. So this is a HBB gene structure. And here we can see epsilon, gamma, both G and A type, delta and beta. And here, this is the specifically beta part, beta region. We can see 3 exon and promoter and locus control. So mutation can affect at any level, to promoter, to locus control, or to exon itself. It can also involve delta, like in delta beta thalassemia. It can have promoter mutation. So all these, it can affect from transcription to translation and at the level of the protein synthesis. So these are the 5 common mutations which are common in India and contribute around more than 90% of the mutation in the beta thalassemia. These are the common mutation. So whenever we are asking for genetic testing in the beta thalassemia, we can adopt 2 approach. The first ideal one is, because these are the point mutation and rarely deletion type of mutation, we can order them to go for DNA sequencing of HBB gene, which will see the mutation in the complete beta globin chain first. And if we are not able to find out any mutation or mutation in one carrier and not in other, then we should always go for deletion study, because sometimes deletion type of mutation can also the cause for carrier status. So the second, then we can go with gap PCR or MLPA deletion study. Second approach is, that is actually more cost effective. In case if the cost is the factor, we can go with the specific mutation study by using allele specific PCR like ARM PCR for common mutation, which I have already told you. These are the 5 common mutations which contribute around 90% of the thalassemia patient in our country. So we can go first with the allele specific PCR or ARM PCR. And if we are not able to find out any mutation, then we can go with the DNA sequencing of complete HBB gene. So in the end, my take home message is, periconceptional period or early pregnancy period is the best time to approach the couple, because at this time couple is most receptive because they want a healthy child. And the second thing is the stepwise approach for beta thalassemia or hemoglobinopathies. Screening is required and prevention is always better than cure. So my sincere thanks to Dr. Seema Thakur for case contribution, and thanks to all for patience listening.
ठीक है मैं एक मिनट मैं मीटिंग में ठीक है ओके सो मैं मीटिंग में हाँ मैं भेज दीजिए ओके सो थैंक यू डॉक्टर गीतांजलि for such a wonderful talk. Now I request Dr. Madhulika and Dr. Deepti to give any inputs.
Thank you, Dr. Seema. It was a wonderful talk and a very comprehensive talk by Dr. Gitanjali. And as we all know, the crux of matter here is prevention is better than cure. And as obstetricians, we should be very clear that no baby is born with a severe hemoglobinopathy. CBC, peripheral smear, and HPLC is a must at all first natal visits. And we should all know that genetic counseling for prenatal diagnosis, when to offer and whom to offer, every obstetrician should know. Actually, this sums up the whole thing, what Dr. Gitanjali wanted to say. Thank you.
Yeah. So, yeah, Dr. Deepti, Dr. Vandana. So, Dr. Vandana is expert for the today's session. Dr. Vandana Chadda, are you there? Vandana?
Yeah, thank you, Seema, for inviting me here. And I see there is a question in the chat box which says that, can you please repeat the ones which require prenatal diagnosis? I think that is the main interest of the obstetricians, that which are the common ones which we have to be careful about. So definitely the combination of beta thalassemia trait with a beta thalassemia trait will have a 25% chance of producing a transfusion dependent baby, and all of us are aware of that. Along with that, a combination of beta thalassemia, a sickle with any other combination. So a sickle with E, a sickle with beta thalassemia, or a sickle with D, all of those would interest us, because a sickle with a sickle, all of that will require prenatal diagnosis, because there is again a possibility of transfusion dependent anemia. E trait and E trait combinations don't require PND, because the E homozygous don't really require transfusion. So a lot of the patients who come from the northeast side, you will notice that they have E trait, and we don't have to bother if both the partners are E trait. a combination of E-trait with beta thalassemia, as was mentioned in the talk, is sometimes tricky because sometimes they are transfusion dependent and sometimes they are intermediates. But for practical purposes, we do offer PND for a combination of E-trait with thalassemia. The rest of the things are rare, and possibly the obstetricians should be well versed with these common situations. Another one is a combination of D Punjab with thalassemia, which does not require prenatal diagnosis, or a combination of Punjab D with Punjab D also does not warrant our attention. So I think that pretty much answers the at least the common.
Most of them would require genetic counseling though. So for an obstetrician, it's beta thal. Beta thal is, anyway, they have to refer for the CVS. But for anything other than beta thal, if they're finding hemoglobin D Punjab or E or S, they should refer for genetic counseling. Prenatal testing will be decided by the, the fetal medicine specialist or the genetic specialist. So anything other than beta thal trait, that should be referred for the genetic counseling. Because at times there may be silent carrier, at times there may be hemoglobin D Punjab plus beta thal, the patient herself, and the father is a partner, the partner is a carrier. So anything other than beta thal requires genetic counseling, and whether prenatal to be done or not, that has to be decided by the fetal medicine and genetics people. So, So thank you, Vandana, for your valuable inputs. Now I request Dr. Bharti to conclude the session.
Thank you. Am I audible? Am I audible?
Yes, yes.
Actually, I'm not at home, so I'm outside, but I was very much into the session. It was a very informative and very crisp session. I just want to add one more thing on the, this complete blood count. That can also tell us that whether it's an iron deficiency anemia, because there in peripheral smear, we can see that it's microcytic hypochromic anemia. But if the Mentor index, that there is one term, Mentor index, that in that we just take the mean corpus MCV and RBC count actually. If we, MCV count upon RBC, MCV value upon RBC count, if we take it, if it is less than 13, that is highly suspicious of the thalassemia. So that simple blood, complete blood count, that can give us the, clue about this, whether the patient is simply iron deficiency anemia or beta thalassemia. Rest everything has been covered, I think.
Yeah,
so
just to simplify, how on the basis of CBC, you highlighted a very good point. Calculation of Menger index in the busy practice, probably they would not be very well versed. So what we generally do, 75-25, like 75 is the MCV, if it is less than that, and if the MCH is less than 25, in association with low hemoglobin and raised RBC count, that gives us a full suspicion of beta thalassemia, and HPLC should be ordered. So this we generally, particularly not in the private setup, this is very important in the government setups, because there the resources are limited.
Yes,
so
in low resource. Yes, low.
You raised really a pertinent point, ma'am. So thanks a lot for your input.
Thank you. It was a very informative CME otherwise. Thank you so much. Okay.
So with this, now we conclude, we move on to the second session. And now I request Dr. Leena to introduce the chairpersons for this second session. Dr. Leena. Yeah. So Himanshu, please share the CVs. Dr. Leena, are you there? Okay, so the second talk is on the Hydrops fetalis, and I would like to introduce our chairpersons for the same. And it's my pleasure I'm delighted to introduce Dr. Neeru Kiran Banerjee, who's a dynamic obstetrician in this area. She has done her MBBS and MD from MGIMS Sevagram Varda, and currently she is practicing in Dwarka since 1990, and she has been an ex-lecturer at MGIMS Sevagram and past president IMA Dwarka. And in Dwarka, if anybody needs any obstetrician CME or any IMA CME, they will contact her. She is a prominent figure in Dwarka. So welcome, Dr. Neeru. Next slide, please. Himanshu, next slide. So our next chairperson is Dr. Vijay, and he is the head of the Department of Minimal Access and Robotic Gynecology Surgery at Manipal Hospital, Dwarka. And his area of interest is gynecological surgery on hysteroscopy, laparoscopy, and robotics, and especially laparoscopy and robotic surgery for endometriosis and gynecological carcinoma. And his major achievements have been ex-chairperson Endoscopy Committee, FOXY, and founder president Bhubaneswar Ops and Gynae Society. And he has also been honored by Chief Minister Odisha for his contribution in gynae minimal access surgery. So welcome you, sir. We would love to listen from you. And at the outset, I would like to thank Dr. Tanu Gera, who has, in the last moment, she has agreed to be a chairperson for this session. And she is currently working with me as a consultant radiologist in Fortis Hospital, Shalimar Bagh. And she has got keen interest in the women's increasing imaging, including the fetal and the breast imaging. She has done her MBBS from Maulana Azad Medical College, MD from Lady Hardinge Medical College, and senior residency from Maulana Azad Medical College. So welcome, Dr. Tanu. Now I request Dr. Neeru to introduce our speaker for this session.
Yeah. Am I audible?
Yes, very much.
Yeah. Thank you very much, Dr. Seema and AOGD for including me in this excellent webinar. I think the topic we all look forward to again and again to listen from you all. So without delay, I would like to introduce Dr. Bhavna. I would like to welcome Dr. Bhavna Anand. She's done her MBBS MS in Obs and Gynae. She is FIC MCH. She's working as consultant in the Department of Fetal Medicine, Manipal Hospital, Dwarka, Sector 6, New Delhi. So very close by to us. And her field of interest is obstetric sonography and various fetal interventional procedures. She is a distinguished fetal medicine specialist and has been trained at SGPGIMS, Lucknow, India. She's an expert in handling high-risk cases. She also has an outstanding academic career with several publications in various national and international journals, including Fetal Diagnosis and Therapy and Journal of Maternal Fetal Neonatal Medicine, etc. So when we talk of hydrops fetalis, friends, we all know it's not a disease. It's actually rather, it's a symptom of an underlying health problem that affects the baby. And if left untreated, in the excess of fluid that can stress fetal heart and other vital organs, life at risk. So let's listen to Dr. Bhavna, a fetal medicine specialist perspective on hydrops fetalis. Over to you, Dr. Bhavna.
Thank you so much, ma'am. And good afternoon, everybody. Is my screen visible to all and I am audible?
Ma'am, your screen is visible, but
yes.
we can't see your full screen.
Yeah. Can you please
full screen, Bhavna?
Yes, ma'am, you need to share again.
Good afternoon, everyone. Today, my topic is Hydrops fetalis from a fetal medicine specialist perspective. Although this talk is made by a fetal medicine specialist, but it is meant for everyone because to enlighten our knowledge and to increase the knowledge. So many a times in our practice, in our gynae practice, we encounter such a picture of ultrasound in which there is fluid in every body cavity of the fetus, or in labor ward, we encounter such a baby which is hydropic. So what is hydrops? It means an excess of total body water, which is usually evident as extracellular accumulation of fluid in tissues and serous cavities. It generally presents as subcutaneous edema accompanied by effusion in 2 or more serous cavities, including pericardial, pleural, or ascites. While polyhydramnios or placental thickening are not included in the definition, but they are often associated findings. When the fluid accumulation is limited to one cavity, it is called hydrops, but it should be described in terms of the involved site, as this will be helpful in narrowing the differential diagnosis. Hydrops usually present as end stage of disease and is associated with poor prognosis. So what are types of hydrops? They are mainly divided into 2 types. It is immune and non-immune. Immune hydrops occurs because of circulating antibodies against RBC in the mother. The maternal antibody cross the placenta, bind to the antigen of fetal RBC and cause hemolysis, which leads to severe anemia and hydrops. It is most commonly because of Rh disease. The other all types are classified in non-immune hydrops, that is hydrops in absence of maternal circulating RBCs are all called non-immune type. And because of better availability of treatment for immune type of hydrops, non-immune is becoming responsible for at least 85% of all hydrops. Still, the incidence is quite low, that is 3 per 10,000 birth. The other two special type of hydrops are first trimester hydrops with cystic hygroma, which is usually seen as increased nuchal or cystic hygroma. The evaluation of these type of hydrops are different from that of non-immune hydrops. Other special type is twin gestation causing hydrops, in which hydrops develop in one or both twin because of monochorionic twins and leading to twin-twin transfusion syndrome. So by now we have known that hydrops are of two types. It is Rh or non-Rh. Non-Rh has multiple causes. So this slide is a busy slide, but the main aim to show this slide is that hydrops is a heterogeneous disorder, which occurs because of multiple mechanisms and multiple causes. Different causes exert its effect by multiple mechanisms to cause a single diagnosis called hydrops. So the basically three primary mechanisms of causing hydrops are intrauterine anemia, intrauterine heart failure, and hypoproteinemia. So I'll be talking about the causes of hydrops one by one. First and foremost is chromosomal abnormality. Risk of chromosomal abnormality is high, that we suspect it a chromosomal abnormality when it is identified earlier in gestation or when it is associated with fetal structural anomalies. Main type of chromosomal abnormality affected cause hydrops may be numerical or structural abnormalities. Numerical, the most common cause is Turner syndrome. It may be trisomies of 21, 18, 13, triploidy, or maybe a structural defect in the form of multiple translocations, deletion, duplication, etc. Second cause is cardiac causes. Cardiac causes are also very common. It may be any type of cardiac cause, severe cardiac disease, which is leading to increased right atrial pressure and volume overload. It may be a structural abnormality of heart. Arrhythmias are quite common. Maybe a tumor of heart, infection of heart by parvovirus or any other infection, inflammation, and arterial calcification, which may lead to a cardiac disease, which is severe enough to cause a hydrops. Then infectious causes are taken into account more often. The most common infectious cause of causing hydrops is parvovirus, which has a affinity for RBC progenitor cells and causes hemolysis and secondary anemia. Otherwise, cytomegalovirus is another important cause. Infectious causes are taken into account when there is abnormal finding like echogenic bowel, intracranial calcification, ventriculomegaly, or there is increased MCA-PSP. Then hematological causes are also important in certain ethnic group, like homozygous alpha thalassemia is more common in Mediterranean, African, and Southeast population. In these ethnicity, because of more association of alpha thalassemia, so the suspicion is raised over there. And structural anomalies, they represent a large group of heterogeneous disorder, and they can be identified through detailed fetal imaging. And importance of identifying a structural anomaly is that the cause may be treatable. It may be in the form of a congenital diaphragmatic hernia or a CPAM or a sacrococcygeal teratoma, various type of tumors which may be placental in origin, all may cause hydrops. A single gene disorder, or better called as monogenic disorder, are although rare, but they are important to know because syndrome is a disorder which is characterized by a set of associated symptoms or phenotype. And identification of monogenic disorder, this not only helps in predicting the outcome of current pregnancy, but also has an impact on the management and screening of future pregnancies. So it should be suspected when there is finding of multiple defects. A special mention is required for metabolic diseases. The most common ones are mucopolysaccharidosis, Gaucher's disease, and GM1 gangliosidosis. The main aim to know about these rare defects is that the risk of metabolic disease is increased if the hydrops is recurrent for the same couple, or if there is a family history positive for metabolic disease or hydrops. And antenatal recognition of these disorders is of great importance, because most of these disorders are autosomally transmitted in autosomal recessive fashion. So they have 25% recurrence in each subsequent pregnancy. Early initiation of postnatal treatment may significantly delay the disease progression, and there is a risk of early death before the diagnosis is established. So importance of doing a prenatal diagnosis in these cases. These cases can be suspected on ultrasound and have a clue, because the the fetus usually present with severe hydrops with massive ascites, very thick skin with coarse facies, contracture deformities, skeletal abnormalities, along with hepatosplenomegaly and renal abnormalities. So now when we have known that what is the etiology of hydrops, how does it occurs, and how to evaluate a case of hydrops. A systematic prenatal evaluation is important, not only for management of current pregnancy, but also for future genetic counseling. Some situations may be a medical emergencies, particularly after 16 to 18 weeks. So urgent referral to high-risk maternal fetal unit is necessary. And the triage depends on gestational age, whether it is in early gestation or in late gestational age, what is the etiology if we have known up to now, and what is the severity of hydrops. So the systematic diagnostic evaluation include a maternal evaluation by prenatal ultrasound and invasive testing, and if a newborn is born or a dead fetus is there, then how to evaluate it. So first of all is a systematic maternal evaluation. In the medical history, we should take a detailed history about her history of any viral exposure or illness, a traveling history.
You cannot see your screen, Dr. Bhavna. I cannot see your screen.
Okay, ma'am. Resume share. Ma'am, is it visible now?
Yes, yes, yes.
Okay, thank you, ma'am. So a detailed medical history is important. Any bleeding in pregnancy or use of medication during pregnancy may also give a clue. Then previous history of diabetes, preeclampsia, anemia, or autoimmune disorder like SLE, thyroid disorder is important to know the cause of hydrops. Obstetric history include a detailed history focusing on mother's past medical and reproductive history, ethnic background, consanguinity. Better a 3-generation pedigree should be made, and which includes specific question on fetal loss, death in infancy, developmental delay, or any congenital malformation syndromes. All should be included in the history. Blood test should be done on the mother, like blood group and ICT. KB count if needed, if there is suspicion of any fetal-maternal hemorrhage, if there is maternal bleeding. Then a complete blood count, which with HPLC should be done. Blood sugar and HbA1c level should be done to exclude the diabetes. Then an infectious screen, whenever relevant, should be done, including VDRL, TORCH, IgM, IgG, parvovirus, and group B streptococcus. Antibody screen, autoantibody screen is necessary for SLE or to diagnose anti-Ro, anti-La antibodies, thyroid. Then liver function test, uric acid, coagulation test if it is suspected Miller syndrome, and in certain ethnic group, G6PD deficiency screen. Testing of alpha thalassemia is also important in certain ethnic group. And carriers are suspected on the basis of microcytosis with normal ferritin. This we have already discussed in detail, that the presence of HBH antibodies in peripheral blood smear are indicative, so parental mutation testing may be done. For infectious causes, an archived serum from routine first trimester baseline test is very useful, and whenever it is available, it should be used to establish the diagnosis. Because it will help us in establish prior immune status and to then document the seroconversion. And testing for rare infectious diseases like syphilis, enterovirus should be considered in particular clinical situation, like there is specific ultrasound finding or mother is HIV positive or clinical symptomatology is there. Then a fetal ultrasound may indicate a pattern typical of a particular infectious agent also. So the ultrasonologist should be take this into account. And lab method to include differentiate between infection is serology and direct virus detection. Serology, although is very sensitive, but it cannot often conclusively determine the time of infection, which is critical for risk assessment. So IgM is more indicative of recent infection. However, it may persist for several months. It can also be negative at the time of hydrops if seroconversion occurred several weeks earlier. And there are biological and technical difficulties which are common and may cause false positive and false negative results. So the importance of prenatal ultrasound, although the diagnosis was made basically on prenatal ultrasound only, but the maternal investigation and ultrasound should go hand in hand and should be done simultaneously. Ultrasound can also give a clue about the etiology and also about the progression of the disease and prognosis. The distribution of fluid collection may give a clue to the etiology, that whether if the fluid is more located in the thoracic cavity, then a thoracic cause is suspected, or it is in the abdominal cavity. Then ultrasound marker of aneuploidy, they suggest a cause like chromosome or a syndrome. Then a degree of polyhydramnios and cervical assessment should be done to exclude risk of premature rupture of membrane or preterm labor. A systematic fetal anatomy assessment should be done in detail to reach the diagnosis. Like fetal bladder visualization may be done to exclude fetal urinary ascites. Then a bone length, skeletal examination, including bone length, curvature, density, and presence or absence of fracture to exclude skeletal dysplasia. Then a stigmata of congenital infection like microcephaly or intracranial calcification should be seen and observed. Umbilical cord or placental anomalies may also indicate the cause. And then semi-quantitative measurement of fetal heart failure may indicate the prognosis in that particular case. So as I have discussed that there is a special pattern of typical infectious agent. For example, CMV, cytomegalovirus exert its effect on all the organ system like intracranial, cardiac, abdominal, and placental abnormalities, while Toxoplasma has no cardiac effect, syphilis has no intracranial or cardiac effect, so we should also keep in mind. Then MCA PSV measurement is a very useful test after 16-week gestation to assess fetal anemia. It is essential. PSV more than 1.5 MOM has 95 to 100% sensitivity for detecting fetal anemia. Abnormal DV waveform also help to identify the fetus at risk for cardiac anomalies and to predict prognosis. The most useful predictor for perinatal death is presence of absent or reversed diastolic flows or venous pulsation. So the Doppler study is necessary. Then a fetal echo is also important to assess cardiac anatomy, rhythm, because as we have discussed, congenital cardiac malformations are common with an underlying genetic syndrome or a chromosome anomaly. Cardiac arrhythmias may be primary or may be secondary to a systemic etiology like hyperthyroidism or autoimmune conditions. The two most common fetal arrhythmias which we encounter in hydrops are supraventricular tachycardia or bradyarrhythmias associated with complete heart block. So invasive testing should be done thereafter, which include amniocentesis. Amniocentesis should be done and sample should be sent for karyotype and microarray testing, which are must. Then viral DNA PCR for CMV, parvo should be done. Cultures for syphilis, CMV, toxo should be done whenever they are relevant or there are clinical symptomatology is there. AFP levels whenever it is relevant. Then a targeted metabolic investigation can be done in special circumstances, what we have discussed at if the hydrops is recurrent or there is family history. Then genotyping through panels or whole exome sequencing are recent testing. They should be done whenever relevant. We will be discussing it in later on. Chordosynthesis should be done depending on the gestation age of the fetus. The sample should be sent for complete blood count, platelets, direct home test, blood group, rapid karyotype, torch and parvo B19 viral DNA PCR. And whenever a cavity is available in the hydrops, it may be aspirated and the sample can be sent for lymphocyte count or biochemical studies to reach the diagnosis, what is the type of fluid in it and whether it is treatable or not. Then the amniocentesis versus chordocentesis depend on gestational age of the fetus. Although if the chordocentesis, if the gestation age is advanced and chordocentesis is feasible, then prelims result are available within 24 to 48 hours. So it is important. Chordocentesis also help in cases with high MCA PSV or documented parvo B19 seroconversion, or there is parenteral microcytic anemia from at-risk ethnicity and documented fetal bleeding. So whenever fetal anemia is detected through chordocentesis, O-negative maternally cross-matched blood can be transfused in the same sitting to save the fetus. In a specific situation, like there is positive family history or recurring hydrops, a targeted metabolic investigation should be performed, we also said. The option to pursue a single gene etiology depend on appropriate history and clinical suspicion. After all this systematic examination, up to half of the cases of non-immune hydrops remains unknown after evaluation of these standard testing. So the further testing is to estimate the frequency of monogenic diseases, especially in fetuses with developmental defect. It is very justified to perform the gene panel or even whole exome sequencing. So while making this presentation, I encountered a very recent paper published in 2021, in which they have compared exome sequencing with the targeted gene panels for evaluation of an NIHF. And they concluded that the broader coverage of exome sequencing for genetically heterogeneous disorder like non-immune hydrops made it a superior alternative to targeted gene panel testing. So there is a role of whole genome sequencing in evaluation of hydrops, especially if the cause is unidentified after many investigations. So what is the treatment option for hydrops? So fetal hydrops is a medical emergency that mandates rapid evaluation. Treatment depend on etiology and gestational age at diagnosis. Fetal chromosome anomaly, if the gestation age is less than 24 weeks, and if it is a structural anomalies other than chylothorax, these are indicator of a poor prognosis. While fetuses with pleural effusion, they are associated with poor outcome because they have lung compression and pulmonary hypoplasia. Other causes like fetal tachyarrhythmias, isolated ascites, and hydrothorax, they are associated with better outcomes. So excluding chromosomal abnormality, the survival rate is about 31 to 48%, which is quite low. When a pregnancy is continued with known fetal hydrops, occurrence of maternal mirror syndrome called Valentine's syndrome should be carefully monitored. It is development of maternal edema and severe preeclampsia secondary to fetal hydrops. Other maternal complications which are associated with hydrops are polyhydramnios, preterm labor, postpartum hemorrhage, and amniotic fluid embolism. So they should also be considered when a pregnancy is continued with known case of hydrops. So what are the potential treatable causes of hydrops? Cardiovascular, yes, if it is an arrhythmia, it can be treated by giving a transplacental or a maternal antiarrhythmic drugs. Hematological disorder, to some extent, alpha thalassemia can be treated with variable results by doing an intrauterine transfusion. There's no treatment for chromosomal disorder. Infectious causes, yes, IUT can be done for parvovirus with variable results. Then thoracic causes, like if there is thoracic mass or CPAM, then it can be treated by doing a thoracoamniotic shunting. Syndromic cause, no treatment available. Then placental causes like twin transfusion syndrome or a large choreangioma can be treated by doing a laser therapy. And there is no treatment for lymphatic dysplasia, idiopathic, and other causes. So intrauterine therapy, fetal therapy may be done in form of intrauterine transfusion for anemia, which we have discussed the various causes of maternal fetal anemia like RH immunization, maternal fetal hemorrhage, hemolysis, or parvovirus infection. A repeated centesis or shunt insertion may be done in case of pleural effusion, ascites, thoracocystic lesion, or CPAM, pulmonary sequestration, etc. Then intravascular or maternal antiarrhythmic drugs may be given for cases of tachyarrhythmias or block. Then fetal procedures may be done in CCAM or sacrococcygeal teratoma. A laser therapy may be useful, or antithyroid drugs through transplacental route may be given to treat fetal thyrotoxicosis. So this is a diagram in which a chordocentesis is being done and intrauterine blood transfusion is being given for a anemic patient, anemic fetus. This is called transplacental blood transfusion in the cord, umbilical vein, and then in the hepatic vein, and then in the intraperitoneal, if it is not possible to do a chordocenter, to give in an umbilical vein. And then the MCA PSV velocity is taken into account to check the results of these transfusion. Then this is a slide showing fetal therapy for macrocystic type of CPAM. In this, there was a large thoracic lesion which has multiple cavities. Then a sclerosing agent like OK432 was given and the mass was reduced. And then further the mass recurred, and then a shunt is done to reduce the mass size. So fetal therapy for twin transfusion syndrome may be given through a fetoscopic approach, and the abnormal vascularization is identified and it is cauterized. In this case, a bilobe fetal thyroid enlargement was detected, and then the patient was given L-thyroxine through transplacental route, and the thyroid goiter was treated. So how to deliver a hydropic baby? If the fetus diagnosed with treatable cause of hydrops, they should be delivered in a tertiary care center. And a pre-delivery cavity aspiration like pleural effusion, severe ascites, severe polyhydramnios may facilitate neonatal management, and it reduces maternal complication. Postnatal therapy begins with vigorous resuscitation, including thoracocentesis, paracentesis to establish lung expansion. Once the neonate is stabilized, a detailed physical examination, including cardiac monitoring, chest radiograph, and ultrasound, should be performed, and additional testing is guided by investigation initiated antenatally. If we get a dead fetus with hydrops, how should it be evaluated? It should be referred to a genesis test, and a plan should be made for additional investigation simultaneously. A clinical photograph and fetal X-ray, including infantogram, should be taken. Then evaluation of possible dysmorphic syndrome or skeletal dysplasia should be done, and an autopsy is strongly recommended, at least for non-chromosomal causes. Then a storage of fetal blood, DNA, and amniotic fluid to do genetic testing, infectious screening should be done. Preservation of any potential dividing fetal cells, whichever is available, like biochemical or molecular genetic testing. Then a placental examination is very important, which include microscopy and histopathology, focusing on tumor, fetal anemia, infection, and metabolic disorder. It is indicated. So what to give a recurrence risk, how to counsel the parents, that if it is fetal defect, infection, or sporadic cases, then there is no increased risk. Patient should be reassured for next pregnancy. If it is autosomal recessive cause is found, then they should be given a risk of 25% recurrence in every pregnancy. If it is autosomal dominant, usually they are sporadic. The risk is not increased unless one of the parent is a carrier, then there is 50% risk of recurrence. If it is a chromosomal defect, then risk is increased, especially if one of the parent is a translocation carrier, depending on the chromosomal effect. If it is Rh isoimmunized, then there is increased risk with every pregnancy. So till now, we have discussed all about hydrops, how to treat, what is the prognostic factor. Now, we will be just increase our knowledge by seeing some interesting case scenario. All these cases are not mine, but I have taken it from internet for better knowledge of us. So my case one is a 39-year-old second gravida who presented with history of recurrent hydrops. In her first pregnancy, she was detected hydrops at 18 weeks. USG was suggestive of unilateral clubfoot without any abnormalities. The cardiac rhythm, middle cerebral artery Doppler was normal. Maternal blood group was positive and antibody negative. Amniocentesis done, and it revealed a normal karyotype. Infectious workup was negative for parvo, cytomegalo, toxoplasma, herpes simplex, adeno, and Coxsackie virus. Her diabetes and thyroid status were unremarkable. Termination of pregnancy was done on demand. The autopsy was done, which described a female fetus with serous non-chylous pleural and pericardial effusion, congested liver, hypoplastic lung, cardiac anatomy, placental pathology, and karyotype were normal. Placental cultures were positive for common vaginal flora and negative for fungi and anaerobes. DNA storage was done. Maternal postpartum testing was negative for inherited thrombophilia and EPLA. The final diagnosis of idiopathic hydrops was made. In her second pregnancy, she again developed hydrops at 18 weeks. Her anatomical survey was normal, other than echogenic bowel. A full workup was performed, which was unremarkable. An additional testing, including a KB count for fetal-maternal hemorrhage, HPLC, and G6PD was done. Chordocentesis was performed, which confirmed normal fetal hemoglobin. A lysosomal storage disease panel was done, which was negative for GM1, mucopolysaccharidosis, Niemann-Pick, Gaucher's, and sialidosis. So given the history of recurrent hydrops without any identifiable diagnosis, whole exome sequencing trial with full exome sequencing of parents as well as controls was performed on fetal amniocyte. And the NGS result showed compound heterozygous variant in collagen and calcium binding EGF domains, and the gene leading to the diagnosis of HKLLS1 syndrome, which is HEMCAM, lymphangiectasia lymphedema syndrome 1. So in this case, WES was a useful approach for diagnosing rare single gene disorder like this, and with non-specific phenotype, and this test should be considered early in the diagnostic process of investigating fetal anomalies. Case 2 was a 31-year-old Rh positive primary gravida, which was referred at 31 weeks for further evaluation of cardiomegaly. Her previous ANC was elsewhere, but it was uneventful. Her double marker test was in intermediate range. That is, the biochemical trisomy 21 risk was 1 in 53 and combined risk was 1 in 373. Level 2 scan was normal. Medical and surgical history were unremarkable. On ultrasound, she came at 31 weeks. It was in breech presentation with the femur at 5th centile. There was polyhydramnios and placentomegaly. There was cardiomegaly, which was mainly right-sided. Mild TR, pericardial effusion was present. Mild ascites and hepatosplenomegaly was present. And MCA PSV was less than 1 MOM. On further evaluation, did up amniocentesis, including with chordocentesis. Investigation was sent for blood group, complete blood count, HPLC, KB count, ICT, TSH, blood sugar, torch, IgM and IgG. LA, ACL, IgM, IgG, anti-ROLA antibodies were done for all for mother, and then chordo and amniocentesis done in view of advanced gestational age, and sample sent for rapid karyotyping with microarray, PCR for viral antigen, for CMV, parvo, blood group, platelet count. So the report came and it was trisomy 21. So the fetal prognosis was explained. Patient went into spontaneous preterm labor at 37 weeks. LSC is done, delivered a female baby of 3.6 kg. Postnatal evaluation revealed mild cardiomegaly ascites. Echo was normal and baby was discharged in stable condition. Case 3 is a 32-year-old second gravida at 18 weeks of gestation. Her previous baby died due to heart block and hydrops. Her maternal workup suggestive of positive anti-SSA and anti-SSB antibodies. Regular ultrasound was done to look for any rhythm and abnormality in present pregnancy. It was detected AV dissociation at 24 weeks gestation because it is a recurrent cause. Then she was started on dexamethasone therapy. Heart rate was 90 beats per minute at birth. Baby was fine. So hydrops is a treatable condition in many of the cases. Fourth case was a primary gravida with 24 weeks pregnancy, which was referred for fetal ascites. No other medical or surgical history was positive. Ultrasound revealed fetal ascites with fetal supraventricular tachycardia. Heart rate was 273 beats with AV concordance. She was started on oral digoxin and sotalol. And then she was followed with maternal ECG and corrected QT interval and blood digoxin level to look for any digoxin toxicity. And because of persistent fetal tachycardia, her sotalol dose was titrated and it was increased, and then when she developed sinus rhythm and heart rate was 140 beats per minute and no further tachycardia episodes was identified. Slowly the sotalol dose was tapered on day 13, and as the sinus rhythm was established, fetal ascites was completely resolved. Digoxin dose was also tapered gradually, and regular ultrasound was done to and suggestive of no further episode of fetal tachycardia or ascites. She delivered with the normal vaginal delivery at 38 weeks, and infant had no complication regarding cardiac or neurological, etc., neurological causes. Case 5 was a 33-year-old second gravida, which she came for routine ultrasound. There was no history of any malformation, recurrent abortion, hematological or genetical disorder. On ultrasound, fetus was found to have increased nuchal translucency with bilateral cystic hygroma, omphalocele. So a CVS was done to know the karyotype, which was refused. The patient, because of religious backgrounds, patient did an NIPT, which was high risk for trisomy 21. But she was committed to the pregnancy. She was again seen at 16 weeks, which was showing Hydrops fetalis. And 1 week later, when she came, it was an IUD. Labor was induced. POCs were sent for microarray, which confirmed trisomy 18. So chromosomal disorders occur many often. They may be a reliable clinical pattern or they may not be. Case 6 was a 29-year-old second gravida presented at 12 weeks pregnancy with increased nuchal and cystic hygroma. CBS was done and karyotyping was suggestive of microarray was suggestive of 22q microdeletion or DiGeorge syndrome. And it was also an atypical presentation of DiGeorge syndrome. So case 8 was a 37-year-old primary gravida at 28-week gestation who presented with fetal hydrothorax and placental edema with polyhydramnios. Her maternal workup was suggestive of hypertension, proteinuria, recent onset pedal edema, and ascites. So a diagnosis of maternal mirror syndrome or Ballantyne syndrome was made. Maternal mirror syndrome occurs due to vascular changes in the Solon hydropic placenta, and this require urgent delivery. Fetal karyotype and microarray was normal, but the delivery improves the maternal outcome, so the delivery was pregnancy was terminated. So to conclude my talk, Hydrops fetalis is a clinical description, and not a diagnosis suggestive of a specific cause. Recent progress in prenatal genetic and fetal medicine provide us with newer tools to identify the underlying etiology, and an attempt should be made to identify the etiology. It will help in better predicting the prognosis, offer treatment when appropriate, and assess recurrence risk to plan for the management of future pregnancies. Thank you so much.
Thank you, Dr. Bhavna, for such an informative and elaborate talk on Hydrops fetalis. You have covered almost the entire topic, from the diagnosis, etiology, to the treatment, to the recurrence risk. So now I request Dr. Bijay to give his inputs about this.
At the outset, I must say that Bhavna, it's been a very lucid one, and you have given such a elaborative way that
covered everything.
You have every corner has been dealt with, yes. And but my interest is in that fetal intra-utero fetal therapy with fetoscope. That is quite interesting. As me as a endoscopic surgeon, I must look towards that.
Yeah.
And
so I think when the fetal surgery
you
will
have dealt with all the antenatal, then gestational, and the postnatal periods of the lady. But still, I think this should be at least the immuno one should be assessed very early, even if it can be assessed during the childhood, it is well and good. With any suspicious amount of anemia, one can think of going for HPCL or going for CBC in combo.
Yeah,
so it was a nice talk from Bhavna Anand. And I also learned many things from your slides and from your talk.
Yeah.
It's really good. Nice.
Thank you, sir. Thank you, sir,
thank you
for your inputs. Dr. Tanu, yeah. So we would like to hear from you, and thanks a lot for joining us at the very last moment. I called you.
Thank you, ma'am.
Dr.
Thank you, ma'am, and thank you, AOGD, for giving me this opportunity. Thank you, Dr. Bhavna, for the comprehensive talk. From a radiologist's perspective, I would like to say that whenever we get a fetus with hydrops, if it is early gestation, we think more in terms of chromosomal anomalies, syndromic causes, lethal skeletal dysplasias. And of course, we do a detailed ultrasound evaluation of the fetus, like to look for any tumor, AV malformations, cardiac etiologies, arrhythmias, which you have very well covered in your talk. The most important thing I would like to stress upon is MCA PSV, which is a very important marker for the assessment of fetal anemia. That it helps us to differentiate between immune and non-immune causes, and very important to prognosticate the patient, to follow up, it helps us in management. So I think the fetal MCA is a very important thing which we all should include in our reports. Overall, I think we all have got very good take-home messages from your talk, and they are really going to help us in our day-to-day practice. Thanks a lot.
Yeah. So thank you, Tanu. And I think, Dr. Vandana, we would need your comments, because you have lots of cases. Particularly, I would like to know, the literature says that the 1/3 is only, immune. Do you agree with that?
I think
we have more of
non-immune PC. We are seeing a lot of non-immune now. In the pandemic, I've seen a lot of ascites. I don't know if anybody else has seen much more than we were seeing earlier. So, Dr. Bhavna, I congratulate you for the excellent coverage, and I think she has covered every point. And the 2-3 things which are important from the obstetrician's perspective: which ones are not recurrent, which ones are recurrent, and which ones are treatable. So those things are relevant. So in my own practice, if I recall, the ones which stand out and which had distinct recurrence, and where we also didn't do the diagnosis in the first go, is one case which used to come from Ghaziabad, 2 hydrops, and then we made the diagnosis of MPS 7 in a 3rd pregnancy. But after that, she disappeared, and she said that since the next pregnancy, there was no hydrops, I didn't do any prenatal, and baby is fine. So the MPS 7, though, has a 25% recurrence risk. The patient had her own insight into it, saying that she just followed in the periphery with the ultrasound, and that's how she managed to get a normal baby without hydrops. The other case I remember is where recurrent hydrops was there, and we could not figure out that it is a arrhythmia, because there was no obvious arrhythmia in the baby, only the presentation was hydrops. Only in the 3rd time that we went in and did the anti-Rho, anti-La, and then we thought that it's so that was a lesson for me, because we didn't actually
understand
in the presentation of the first the second hydrop. So those are the 2 things we learned. So for the obstetrician, always remember that for the infections like toxo, CMV and all, don't worry so much. They are not going to recur, because they bother a lot about treating these conditions, and so we are not so much bothered about recurrence in the infection profile. Another point I would like to make, Bhavna, is that we had a spurt of parvovirus in Toronto when I was a resident there. And in that cohort, which was published in the AOGD, there was a increased like developmental delay compared to normal RH, the transfusion.
Normal immune hydrops.
So when we counsel these babies who have parvo infection, I would not actually counsel them exactly like a immune hydrops in terms of the outcomes after transfusion.
Yeah.
And also, if you have like some of these rare antigens, so if you have a recurrent hydrops where you have a Coombs positive and you're not having an RH negative, then you may have some rare antigen also. So always look for the full coverage of the minor antigen panel when you are seeing a recurrent hydro. I think those were the few points I thought we could.
Yes, ma'am.
Yes. Yeah. So thank you, Vandana. So, the cases of SLE are important. Also, there may not be history of hydrops. There may be the history of intrauterine death. because last year we had a case where the first had IUD at term, and of course there was, before IUD there was Hydrops fetalis, but that usually was taken that this is a part of the IUD. So in the next pregnancy, around 16 weeks, she developed the Hydrops fetalis, and this time, the heart rate was low, and then she was diagnosed as the SSA and SSB positive. So it's important that whenever there is a bad obstetric history, we should try to exclude these, the autoimmune causes as well, because they are treatable. So most important point is to exclude whether it is treatable, non-treatable, and the recurrent and non-recurrent. And also with the NGS coming up in a big way, as per the literature, the yield of microarray is not very high in the Hydrops fetalis. Rather, the yield of the exome sequencing to the extent of 30% is noted, and we have also found the one which you showed, lymphatic dysplasia. So we also have one case which has the recurrent lymphatic dysplasia was found by the exome sequencing. So these are the so wonderful discussions, and so with this we move on to our anything else, Vandana?
Yeah, just last point that if it is isolated ascites, that is the subset which does really well, can resolve it all. So always try to distinguish between Hydrops and isolated ascites. And if it's a very precious pregnancy and there's no fetal anemia, just isolated ascites, it could be a rare unknown infection which resolves, little bit of cardiomyopathy. So you can give that baby a fairer prognosis, and that is a take home, because some of these babies have done very well. So for the obstetrician, when they are prognosticating that particular subset, they may like to give a rosy.
Yeah, so the follow-up that whether it evolves into the Hydrops or whether it remains as such is important. Same is true for the pleural effusion also. When I was working for a few years with Apollo, they had one case of isolated pleural effusion. And that after birth, the mass, so they did all the testing and nothing was identified, and they continued. After birth, the TMS was sent, and that suggested raised C3, which is the suggestive of propionic acid metabolic disorders. And then so then I referred the case to the AIMS, and then they did the maternal vitamin B12. Till then I was also not aware that maternal B12 deficiency can lead to such a big pleural effusion, and that and was fully treatable. So it's the follow-up, the management, so it has to be comprehensive. So many of them, these are treatable, so it's not the end of everything. We need to evaluate, and so that to give the good outcomes. So thank you everyone, all the chairpersons and speaker, Vandana especially, on such a short notice you agreed. So I'm really overwhelmed by Dr. Tanu and Dr. Vandana for their spirit to join at such a short. Actually, the topic is, such a common topic, and it's and such an interesting topic. So I think, we can, so with this, we can move on to our next session. That is a panel discussion. And I request the chairpersons to introduce the panelists for this panel discussion. Dr. Gitanjali. Dr. Bhavna, Dr. Gitanjali.
Yes, ma'am.
Himanshu, please share the the CV slide.
So good afternoon, everyone, and welcome you all for panel discussion. So my first panelist is Dr. Yashika Gudesa. She is head of the department at Manipal Hospital in Obs and Gynae department, and she is executive member of DGF, and she has special interest in adolescent care, PCOD, painless labor and laparoscopic surgery, and managing the high-risk obstetrics. Second slide. Dr. Yogita, she is consultant obstetrician and gynecologist at Manipal Hospital, Dwarka. And she has keen interest in managing the high-risk pregnancy and laparoscopic gynae surgery. And she is practicing in Dwarka from last 10 years. Next slide. Dr. Nidhish Sharma is a fetal medicine specialist working in Sir Gangaram Hospital. And he is trained in fetal echo and fetal intervention procedures. He has keen interest in doing fetal intervention procedures. Next slide. Dr. Savita Dakar, she is a fetal medicine consultant, and she is running her own clinic, Joya Healthcare at Venkateshwara Hospital. And her area of interest is management of high-risk pregnancies, screening and diagnosis of fetal abnormalities, and fetal intervention and therapy. Next slide. Dr. Vinay, he is consultant neonatologist at Manipal Hospital, Dwarka, and he is very keenly interested in research work and he has various publications in national and international journals. Next slide. Dr. Smita Mishra is head of the Department of Pediatric Cardiology in Manipal Hospital, Dwarka. She was past president, National Pediatric and Fetal Cardiology Forum, and she is author of Disability Criteria for Cardiac Patient. Next slide. Dr. Alok Vashne, he is consultant radiologist and director, Central Diagnostic, Dwarka, and he has presented various papers and delivered lectures at various national and regional conferences organized by SFM and Indian College of Radiology. Next slide. Dr. Ritu Garg is consultant obstetrics and gynae at Manipal Hospital, and she is keenly interested in managing the high-risk pregnancy cases and infertility. Next slide. Dr. Prerna Gupta is an infertility and IVF specialist, and she is awarded Commonwealth Fellowship in Reproductive Medicine as Bristol Center of Reproductive Medicine, and she is a keen researcher with more than 50 publications and numerous chapters on her name. Next.
Okay, so I think, yeah, Dr. Gitanjali, I'll just take 2 minutes of yours.
Yeah.
This is a poem written by, as you know, that Dr. Smita is a pediatric cardiologist, and she has keen interest in writing the poems. And these days, her poems are getting viral on the Facebook. So today morning on Women's Day special, she has sent a poem to me. So I thought I'll share with all of you her expressions. So the title of this poem is Crowned Queen, poem on female feticide. So she has written, seated in her mother's womb, terrified she was in silence, holding on to her 2 X chromosomes. As there was a creepy threat, she could be found as she and may have a death sentence. Yet the ultrasound diagnosis went wrong. So she was born, but she never to have a smooth run. 6 siblings were eventually to come. And now she was no more a child, but a stretched dwarf mother. Without even crossing puberty, she grew her shoulders to hold on siblings, sisters, brothers. She was destined to grow fast without a school bag or toy. She was sold to a marriage deal, and she had no dream of Prince Charming. She would smile often and grow her coarse hands working constantly deftly on the household. And one day she conceived a dream. In her womb, some sweet living being, who it was, she or he, no matter what the gender it had, but she felt empowered immense. Then there was empowered to say empathetic no. She found a battle not to undergo for ultrasound and gender hunt. She loved her protruding belly and impending motherhood. Reborn, now she has magical skills. Living behind the old stories, her dwarf moms was now a fairy. She found a raising musical place. She sang to herself and to her baby in the womb, whatever it is, he or she, but it will never be me. She conceived now new dreams too, buying a new school bag and shoes, a school dress in the hanger, and crayons coloring the canvas. Her dreams were lonely for the world, and the dwarf as they could be, but they meant a world for her. She spoke to her silence. Now I would have a voice. Till now, I only knew noise. Through the school of my baby, she or he will be a great human being. Now I know why they crown Ma Yashoda and Lord Krishna, also Mother Mary and Little Christ. A girl in the womb may get a fearful silence and a death threat, till woman has no voice to say an emphatic no to the world. If a woman would care another from the womb to old age, she would win the battle without the man's help. When I was a baby, I never knew I would get my wings back and fly. I would be queen and crowned. My infant would be fearless in my lap, a little prince or princess. So wonderful poem, Dr. Smita. So we welcome you to this webinar. Wonderful thoughts.
so much.
Yes, the female feticide is a danger to our society, and I think we all should work hard. Say no to gender identification. So with this, Dr. Gitanjali, the stage is all yours.
Yeah,
Thank you very much.
A very nice poem and very inspirational also, because ma'am has a good hand over poem, writing poem and so
Yes,
I'm
yes.
sharing my screen and we'll start. I'm welcoming all the panelists. Is my screen is visible?
Yes.
Okay, thank you. So welcome to all the panelists. So I'm starting.
Slides are not there.
Not okay. क्या प्रॉब्लम आ रहा है? Now slides are visible.
Yes.
So shall I start?
Please full screen.
So we are starting our panel discussion. So full screen is here. Is this full screen?
No. Slideshow आप click कर लो.
ये करा हुआ है slideshow.
Ma'am, please share again.
Okay. Now.
Ma'am, start share and use the full screen mode first. There'll be 2 screen share.
Now.
Yes, ma'am.
Okay, thank you. So welcome you all. So I'm starting with my first case. So my first case is Mrs. X, 29 years old, primary gravida, RH positive, non-consanguineous couple. Her anti-scan was normal and first trimester combined screening was low risk, and she presented to us at 21 plus 5 weeks of pregnancy for anomaly scan. So these are the ultrasound pictures we can see here. I'm not able to start my video. So these are the scan pictures.
That's okay.
So Dr. Alok, my first question is to you. Can you describe the ultrasound findings?
Okay, thanks for inviting me. It is always a pleasure to be a part of these academic meetings. So this case shows a large echogenic mass in the left hemithorax. It is uniformly echogenic and there are no cysts. It is causing mediastinal and cardiac shift towards right side, and the right lung appears compressed. And there is no pleural effusion or pericardial effusion. There is no body wall edema. So there is no evidence which suggests there is hydrops. And on sagittal view, we can see that the diaphragm is intact and the stomach is still residing inside the abdomen. So this is not a case of a diaphragmatic hernia. And on Doppler, we do not identify any systemic vessel in the lesion. So bronchopulmonary sequestration is also unlikely. And we do not see any dilated bronchi or flattening of the diaphragm. So lobar hyperinflation or a bronchial atresia is also very less likely. So all these findings, they are most consistent with congenital pulmonary airway malformation or CPAM, which is the most common cause of a pulmonary lesion in a fetus. Since there are no cysts visible in the lesion, so this is the microcystic.
So thank you, Dr. Alok. So can I ask what is congenital pulmonary airway malformation?
So is the most common congenital lung malformation, which is mostly unilateral. It is a developmental anomaly of the lower respiratory tract in which there is an excessive branching and proliferation of the bronchioles and reduced resorption of the mesenchyme around the developing bronchi. So there is an imbalance between the proliferation and apoptosis in the lung tissues. So this lesion in CPAM is it remains connected to the tracheobronchial tree, which is important because lesion is separated and detached from the western.
Your voice is not clear, Dr. Alok.
Can you hear me now?
Yeah, yeah.
So CPAM is a developmental abnormality. Okay, so the lung tissues, they are developing aberrantly, in which there is an excessive branching of the bronchiole. There is resorption of the tissue. There is more development and less resorption, more growth, less apoptosis. And this abnormal tissue, it remains connected to the bronchial tree, which is unlike in bronchopulmonary sequestration, in which the anomalous lesion is detached from the bronchial tree. So thankfully, this lesion is mostly unilateral. This is congenital pulmonary airway.
Yeah, definitely congenital pulmonary airway malformation. They actually can develop at various stages of lung development, but mostly they involve pseudoglandular phase. So this is the reason why there is excessive proliferation of terminal respiratory bronchiole. And there is actually imbalance between the proliferation and apoptosis. So there are three types of CPAM are there: macrocystic type, microcystic type, and mixed. We can see here, this is macrocystic type of CPAM, and this is microcystic and mixture or mixed type of lesion we can also find out. So will type of CPAM can influence the diagnosis, can influence the prognosis of Dr. Alok?
Yeah, definitely it influences the prognosis. So if we consider the natural history of CPAM, it varies from complete regression in utero at one end of the spectrum to life-threatening development of fetal hydrops at the other end. So macrocystic CPAMs, lesions with cysts, they usually do not grow fast. They remain stable over a period of time. But if the cysts are very large in size, yes, they can fill up very quickly, and they can grow fast, and they can compress the IVC, SVC, and cause fetal hydrops. And macrocystic CPAMs, they usually do not regress with gestational age.
Yeah, this is the problem with macrocystic type and mostly require surgery.
Yes.
So my next question is to Dr. Savita. How will you counsel this patient? Dr. Savita?
Yeah, hi, good evening, everyone. So the counseling of a patient of a CPAM depends on multiple factors. First of all, we have to see is the abnormality isolated or it has got associated abnormalities. In isolated cases, then we have to prognosticate the patient on the basis of the CVR ratio. CVR ratio is calculated by calculating the volume of the CPAM and it is divided by the head circumferences. We have online calculators which can help us in calculating the CVR ratio. And if the CVR ratio is less than 1.6 and with no dominant cyst, then the prognosis is very good. And in 80 to 90%, in more than 90% cases, they do very well. And chances of developing hydrops is less than 2%. If CVR ratio is more than 1.6 and there's a huge dominant cyst, then they have good 80% chance of developing hydrops. Usually in isolated cases, there are no associated abnormalities, and in isolated case of CPAM, amniocentesis is usually not recommended to the patients. And as far as the natural history is concerned, in CVR less than 1.6, usually the fetuses do well. We keep the fetuses on a 2-weekly surveillance to look for any features of hydrops. And CPAM usually tends to grow between 22 to 26 weeks. And later on, it outgrows its blood supply and they tend to resolve. And usually the prognosis in a CVR less than 1.6 is good. And if it is more than 1.6, then we have to do a weekly monitoring so that we can look for features of hydrops.
Yeah, definitely. So what is your recommendation to follow, how to follow up in our case? How will
So
you
in this particular case, by looking at the ultrasound images and on the calculation of CVR, it's a microcystic type with a CVR less than 1.6 and then no associated features. So we do a 2-weekly follow-up up to 28 to 30 weeks, and then we can on 3 to 4 weekly basis on 30 weeks onwards, we can follow up. So in this case, the prognosis is likely to be very good.
Yeah. So is this important to look for vascular supply and for these type of lesions?
Yes, the vascular supply helps us to differentiate the CPAM from the other lung lesion, which is bronchopulmonary sequestration. The bronchopulmonary sequestration, or BPS, usually gets a supply from the descending aorta, or it has a systemic blood supply, while CPAM has its supply coming from the pulmonary circulation. Antenatal BPS usually has a very good prognosis, and sometimes it can be a little difficult to differentiate BPS from the CPAM because the underlying pathophysiology is the same, that is disorganized development of the terminal bronchioles. Postnatal follow-up of both the conditions is very similar.
Yeah, definitely. So it is actually good practice to differentiate between two lesions. And the thing is, BPS is actually represent in antenatal period, they usually represent more in benign nature. Although both the lesions, they carry good prognosis, particularly CPAM, even if there is no hydrops. And the next question is, Dr. Savita, what is the reason for spontaneous resolution of CPAM in later gestation?
So CPAM, as the gestation advances, the CPAM tends to outward blood supplies. So that is one of the main reasons why they decrease in size with the advancing gestation. Also with CPAM with CVR less than 1.6, they usually tend to resolve as the pregnancy advances. Also, they say it's not that they disappear, it's just that they are less visible on the scan. They become more equilucent with the remaining lung.
Okay. So, Dr. Alok, if we see on ultrasound there is no lesion, is there any need to follow up even if we are not able to see the lesion? Dr. Alok?
Of course, we should be following up these lesions because lesion is still there. It's not gone. It is, even if it is not visible, it is still present. And we should look for the mass effect caused by these masses, whether it is increasing or decreasing, and check for any development of hydrops. In some cases, there can be development of polyhydramnios, which indicates esophageal compression. And we should be assessing the development of the contralateral lung as well. And also we should be checking fetal growth to make delivery decisions. And in my opinion, there is another very important point that these follow-up, it gives us a chance to revisit our diagnosis, because in certain cases, the vascular supply may not be apparent at first, it can be apparent later on.
Yeah.
Or in cases of bronchial atresia, the bronchi, they will be fluid-filled and they will be apparent only in the later part of the gestation. So sometimes we have to keep following up and revise our diagnosis.
Yeah, definitely in follow-up scan, we may get some additional information which can be useful for managing the pregnancy well. So my question is, if lesion is not evident on ultrasound, so if it is not evident on ultrasound, then why we are like unable to pick up these lesions if it is present? You are saying that mostly they remain present because in 10 to 20% cases only they usually get resolved, and in rest of the cases they are present but not visible on ultrasound. So what could be the reason for this?
So the first reason is because some masses of CPAM, they remain stable in size, but the rest of the lung, the rest of the chest, they grow. And so it is relatively smaller, it becomes relatively smaller. And then the lesion per se, it becomes, it changes its echogenicity with time. And the normal lung, it becomes more echogenic with advancing gestation. So there is the differential contrast between the lesion and the lung that is lost with advancing gestation. So we are not able to pick it up.
Yeah,
But
yes. So because of the loss of the lung cyst contrast is missing, that is the reason why we are not able to pick up the lesion in later gestation. And but it doesn't mean that lesion is gone. So we should be very, very careful. So Dr. Alok, is there any method to differentiate that whether the lesion is present or not? Because we know that in 10 to 20% cases, lesion can resolve also.
Yes, see, anyways, we are not bothered about small lesions. We are bothered about the large ones, which can cause hydrops. So we should be looking for the mass effect caused by these lesions, the mediastinal shift, the cardiac shift. This is what we are looking for. And in some cases, even if the lesion is not visible, the patient is developing hydrops or polyhydramnios, we can always order an MRI to look for the lesion. It will be seen on MRI.
Yeah, definitely. So Dr. Savita, can you tell us what are the indicators for development of hydrops in a case of CPAM? Dr. Savita?
So chances of hydrops developing are usually between 20 to 26 weeks, because this is the time when the CPAM is likely to grow. So that's the most period where we have to vigilant for looking for the hydrops. Hydrops, as we know, we prognosticate on the basis of our CVR. So if the CVR is more than 1.6, then the chance of developing hydrops are more. And if it is more than 1.6, we have to follow weekly. And if CVR less than 1.6, then we can follow up on 2 weekly basis. Also, we have to look, is there any dominant cyst and is there any mediastinal shift? If there's a dominant cyst and there's a mediastinal shift, then there's more likely to compress onto the large vessels, which can lead to our hydrops and other feature. So mainly the CVR calculator, dominant cyst, and the extent of the mediastinal shift will be our deciding factors leading to the hydrops.
So now you know our case is actually showing good promising features. So how will you follow up this case?
In a low risk case, we can follow on 2 to 3 weekly basis, and in our case, like it was it looks microcystic with the CVR less than 1.6. So on 2 to 3 weekly basis, we can follow up look for the feature of hydrops. Had it been the opposite side, then we could have been the frequency of monitoring can be almost on 2 to 3 times in a week, depending on the features of hydrops.
Yeah, definitely. Actually, the decision of follow-up is actually case-based. It is not uniformly constant for each and every case. So our follow-up protocol actually changed according to whatever we are getting in our ultrasound. So whenever, as Dr. Savita has already explained, that because gestational age is an important factor, whenever the gestational age is in between 20 to 26 weeks, and CVR is more than 1.6 means high risk group. So we should follow up them weekly. And if gestational age is 20 to 26 weeks and CVR is less than 1, then 2 weekly follow-up is also adequate. And if the gestational age cross the rapid plateau phase, like more than 30 weeks, and CVR is also less, then we can decrease the follow-up and like four weekly or monthly. So thank you, Dr. Savita. So one more question is there any role of antenatal intervention in CPAM?
Yes, in case of CVR less than 1.6 and microcystic cases, on a routine basis, we do give beta-methasone 20 milligram 24 hours apart, like we give for our fetuses less than 36 weeks for lung maturity. Though there is a controversy about it, but I do give to my patients with CVR less than 1.6 and microcystic case. And but
so you are giving beta-methasone to all the cases of CPAM, or if the CVR is more than 1.6?
Even in more than 1.6 also will give, but in 1.6 the CVR, then the beneficial effects are likely to be less. So in those cases where the CVR is more than 1.6, we have further options. We can, if the large dominant cyst, then we can think of thoracoamniotic shunting. And also the option of fetal surgery is available in the cases where there is severe hydrops with ascites, where we can do open fetal surgeries and excise the mass. Well, not all centers have the facilities of thoracoamniotic shunting and fetal surgery. So the role of steroids will be more useful in cases with CVR less than 1.6 and and with no dominant cyst. Dominant cyst, large cyst, and already you have hydrops. So we have to look for other options in those cases, like thoracoamniotic shunting and open fetal surgeries.
Yeah, definitely. If there is hydrops with the dominant macrocystic CPAM with dominances, definitely we have to give some treatment. Otherwise, it will carry a very poor prognosis. So, thank you, Dr. Savita. Dr. Bhavna, can you, how will you counsel and plan for delivery in this case?
Hello. As we know, the prognosis is favorable in our case. We will counsel them to follow up the pregnancy with routine antenatal care and ultrasound monitoring of the lesion and growth of the fetus.
So when will you deliver this patient? What will be the mode of delivery?
So because it is has a favorable prognosis, so we will allow the pregnancy to reach till term, and CPAM per se is not an indication for cesarean delivery. However, it may be considered for obstetric indication.
Thank you, Dr. Bhavna. So, Dr. Vinay.
Hi, ma'am. Good evening, everyone.
Yeah, welcome, Dr. Vinay. Is there any specific care required at the time of birth in these neonates who are antenatally diagnosed with CPAM?
So, thank you, AOGD, for giving me this opportunity. Because the mass is inside the thorax, so such kind of baby may having respiratory distress. So may require some kind of respiratory support in the form of either CPAP, or some baby require even ventilatory support also. So this kind of baby require advanced resuscitative measures and respiratory support after birth. So we have to prepare according to that.
Yeah, definitely. So now you know that the baby is antenatally diagnosed as CPAM. So, and suppose if the baby is not symptomatic at the time of birth, then how will you follow up these babies who are asymptomatic?
So in all babies, if the antenatal ultrasound is showing some kind of congenital lung malformation, so first test is to do chest X-ray test in all kind of CPAM cases. And if the baby is asymptomatic and chest X-ray is suggestive of the mass is at multilobar kind of, it's a big size involving more than 20% of a particular lobe, or associated with mediastinal shift or some kind of causing mass effect, or having pneumothorax, then immediately we have to do contrast enhanced CT scan. And according to me, in all kind of cases, if the baby is even asymptomatic also, we must do CECT to confirm our diagnosis after birth.
Okay, thank you. And is there any requirement of surgery in CPAM for to all the cases, or it will depend on type of CPAM?
So in some kind of, depending on, CPAM volume ratio, in most of the cases, almost, nearly 99% of the cases require surgery, and various research have, shown that when we are doing surgery on emergency basis, suppose we, we are allowing to spontaneously resolve the CPAM, then, and suddenly baby is having, kind of pneumonia or some kind of, respiratory distress or cyanosis, on that time when we are doing, surgery, so the risk of complication is very high. So according to me, even if, CPAM is asymptomatic, so we must do surgery between, 6 to, 12 months of age, so that the child has, ability to compensate the, resected mass, volume. So according to me, surgery, we must do surgery between 8 to 12 months of age, even if it is asymptomatic. But it's
so according to you, it is better to go with the planned surgery, and it should be done early in first year of life. So
if it remains asymptomatic, it's not causing any kind of cyanosis or respiratory distress, or not a child having frequent pneumonia, so we can wait up to 8-10 months, but it must be done before first year of age.
So what are the advantages of early surgical removal?
So it's a early lobectomy avoids long periods of observation, preventing the need of ionizing radiation, like doing repeated CT scans. And there is also loss of, we can lose patient by doing frequent tests or frequently following up. And the risk of complication like recurrent respiratory infection is also very less. And in some kind of cases like, type 4 or type 1, there is risk of malignancy, so we can avoid those risks also.
So definitely, if we are getting a case of CPAM, and if there is no sign symptoms of hydrops, we are not having any features of hydrops. So always give the positive message to the couple, because the CPAM is a benign condition. Mostly it gives a very favorable prognosis, and it is a totally correctable condition postnatally.
Yes, ma'am. Prognosis is very good when we are doing, surgery at right time. And, most of the kids, especially, type 1, or if not associated with other congenital anomalies, most of the kids they do very well in their, childhood or later during adulthood period.
Thank you, Dr. Vinay.
Thank you.
Thank you. I will now move to my second case. Second case is Mrs. X, 32 years old, second gravida, para1 live 1, RH positive, came to us at 26 plus 5 weeks of pregnancy for growth scan, and her anti-scan and anomaly scan was done outside. It was suggestive of normal report. Her first trimester combined screening was also low risk. So ultrasound findings were, so these were the ultrasound finding in this case. So there is some problem in my video. So Dr. Alok, can you describe the ultrasound finding? Dr. Alok? Dr. Alok?
You can describe since he is not there.
Yeah.
Bhavna?
So we can see.
Dr. Gitanjali?
I am describing this. Because we can see here in the 4-chamber view, it is looking absolutely normal. We can see that interventricular septum appears intact, and 4-chamber is looking fine, totally fine. And we can see that right ventricle is on the right side, moderator, because of the moderator band. And here we can see this is the 5-chamber view, which is actually looking abnormal, because opening of the left ventricle, we can see here the vessel which is arising from the left ventricle, that is after its origin, soon it is dividing. So that means this is not aorta, and the second vessel which is arising from the right ventricle, and this is aorta. So that means there is atrioventricular concordance with ventriculo-arterial discordance. And here we can see in this image, there are parallel outflow track. And similar finding we can see here, the ductal arch and aortic arch. We can see the ductal arch, this is ductal arch and this is aortic arch, which is arising from the ventricle, which is more on the anterior side, while ductal arch is arising from the posterior chamber, which is left ventricle. So the diagnosis is complete transposition of the great vessel. So Dr. Savita, what information you want to gather prior to the counseling of this patient? Dr. Savita?
So the counseling of this patient is very important. It will be a multidisciplinary approach in case of TGA, because if TGA appropriately, antenatally and postnatally managed, has a very good prognosis, very good survival rate. So when a patient, we pick up such diagnosis, then we have to do a detailed fetal echo, and we have to keep a pediatric cardiologist in loop. And whenever we pick an abnormality, we have to look for any other associated abnormality. So our level 2 scans have to be very detailed. A detailed fetal echo needs to be done. Usually TGA are isolated, and in isolated cases, the risk of abnormalities, chromosomal abnormalities, is quite low. So, and the cardiac evaluation, we have to look whether the ventricular septum is intact, or it is associated with VSD, or there are arch abnormalities, associated pulmonary stenosis. We have to look at the foramen ovale, whether the foramen ovale is moving freely or there's a restricted movement of foramen ovale. Also, we have to look at the origin of the coronary arteries, if there's any anomalous origin of coronary arteries, because these will have an important role in our management at the time of delivery, in the postnatal management, with the pediatric cardiologist and the neonatology team will require. So the entire prognosis will depend on our detailed level 2 scan and a detailed cardiac evaluation, and we have to have a pediatric cardiologist completely involved in our antenatal care of this patient.
Thank you, Dr. Savita. So my next question is to Dr. Smita. How will you do the counseling in this patient, as she is already 26 plus 5 weeks pregnant, and we are having the features of transposition of great vessel? Dr. Smita?
Mostly all points has been covered very well by Dr. Savita. So obviously the counseling is about the, because this is now 26 plus 5 weeks. So counseling is all about the future course of the action, because termination is not the option as of now. So what will be in utero, natural history of a TGA, mostly it is very well tolerated during the pregnancy, because the biggest problem what we have after birth is the desaturation of a baby. But here you know that oxygenation is happening in a kind of circulation which is parallel, and mostly the right and left side saturations are same. So so in this particular case, pregnancy in itself remains okay. Then we have to decide about the management of a baby when it is born. So one thing is should it be a normal delivery or should it be cesarean? So there's no reason for the termination of pregnancy any weeks before, unless there are some obstetric indication. Very rarely a TJ may present with the things like arrhythmia, which may happen in normal pregnancy also. And these are the things where the failure is happening, flutter is happening, then only the chance of having cesarean is there. But otherwise, if parents are ready and obstetrician is comfortable, they will go for a normal delivery at normal designated period. And then where to deliver a baby. So like recently we had a patient with the complete transposition with intact ventricular septum. So as Dr. Savita rightly pointed out, that we have to be knowing what is the status of the shunts, prenatal shunts, that is the patent foramen ovale and ductus arteriosus. So if they are working well, then definitely we are very comfortable. And particularly if a patient has, instead of intact ventricular septum, has a VSD, then we are more comfortable. But if it is an intact ventricular septum, then after the birth, we have to do something special. So we should know about the status of interatrial connection and the ductus arteriosus. So for a tertiary care center, we can always, like in this particular patient, we planned a delivery with Dr. Vinay in our own setup. And after that, we kept our prostaglandin ready, and a balloon atrial septostomy, which used to be a procedure before. Nowadays, we don't opt for that. Even an early or surgery is needed, it is done, because there are some side effect for the balloon atrial septostomy also. So the patient was delivered properly. The tertiary care center was figured out according to beforehand with the counseling with the parents around say 8 weeks before, and then the patient was kept on constant monitoring in our own NICU, and with the comfort of the parents, the NICU and the tertiary care center, the baby was transferred. And there they did directly arterial switch operation, and baby was absolutely fine in the 10 to 15 days. So this is, and now baby is doing very well. So these are the things which we actually projected. These kind of outcome we projected to parents, and the outcome was absolutely what we expected. So this is how we do counsel.
Yeah, thank you, ma'am. Actually, you have answered all the questions which I was about to asking. So everything you have explained. So because we know that there is no risk of intrauterine demise in utero, and we can follow up the pregnancy 4 weekly for growth scan, to monitor the growth also, as well as the cardiac evaluation. And as ma'am has already said that there is no need to deliver early in this condition. But I want to ask one question that ma'am, you want to see the cardiac status just before delivery. So when you want to plan the last antenatal scan in this case?
So Dr. Gitanjali, nowadays there is a lot of coordination between the radiology or fetal medicine people who are getting more scan in between. So as a pediatric cardiologist, most of the time I am very comfortable and I just look towards the end of pregnancy when a obstetrician is planning for the delivery. So 1 week before or in the same week when the delivery is planned, I can go for in another scan. And unless there's any change in the cardiac size and all, if any the ultrasound before that done by either radiologist or by the fetal medicine person, and if they find something happening which is not actually not gelling with the whole diagnosis, like the development of coarctation of aorta, that may be there. Development of PFO, restriction of PFO, that may be there. There may be arrhythmias, and there may be cardiac dysfunction. So these are the things, if they are getting in the scenario, then we have to change our plan. Otherwise, it is okay for me that last week when delivery is planned, that week I get one scan. Then one more thing you have asked about the physiological hemodynamics of the TGA. That is that we know, as I said, that it's a parallel circulation and during the antenatal period. But the main issue is that in a TGA, the systemic venous blood enters into right side of heart and it goes back to aorta. The pulmonary blood enters into left side of heart, it goes back to pulmonary circulation. So these are the two parallel circulation happening. Unless there is a shunt lesion like atrial septal defect, ventricular septal defect, and ductus arteriosus, there cannot be any mixing anywhere. So in antenatal period, it will cause no issues because around the saturation in the right side of heart is around 70-80%, and the same is on left side because same blood is moving towards the left atrium, and through the ductus, it is same blood is moving in the descending aorta. But after the birth, when you need pulmonary circulation more saturated, and then you are not getting that for the system, for the aorta. And one thing I would like to highlight, that ductus we can open with the help of prostaglandins, but problem is if PFO is too much restricted, probably this will not work. So that is very important, that PFO should also be adequate.
So I want to ask one question, that is whether we can see the coronary arteries in antenatal scan.
So this is a very good question, and Dr. Savita mentioned it. If you have a very good view, so sometimes we can see. We are not very sure that we are going to look at the coronary, but I am not saying that we cannot see it, because sometimes we are able to actually catch the coronary also, particularly after the 27-28th week.
So I just want to ask one question. Is antenatal diagnosis of TGA, is it better than postnatal diagnosis?
Yes. So prenatal diagnosis, as I said, that the like in this particular patient during the COVID pandemic, the parent, only mother and father were at home with a small child, and along with this there was a pregnancy. So this was the kind of arrangement they had. But because we said that there will be need for a surgery, so they had to arrange for the finance. They had to arrange for the manpower at home who can look after the small child. So these are the things which are very important when you have a prenatal diagnosis, because in postnatal period, when actually baby is really sick, In this case, there was never the metabolic acidosis, there was never the severe cyanosis, which was actually causing the threat to life. So nothing has happened, and baby was very healthy when was given to surgeon. But otherwise, in a postnatal advice, case, sometimes patient cannot be transferred on time. Sometimes there could be infection because you have to give prostaglandin, then you have to intubate also this child. So there's many issues which may arise. So it is always better that you have a prenatal diagnosis and have a in utero transfer near the tertiary care center, not exactly in the tertiary care center, but at least nearby, like somebody is in Muradabad. So that mother should be on the, when this delivery is going to happen, this mother can be transferred on the same week in the that particular city where tertiary care is situated, and then baby can be transferred to tertiary neonatal cardiac care center.
So yeah, definitely. Actually, I want to ask another question: whether even if prenatal diagnosis of TJ is done and a patient is waiting for surgery, like within 2-3 days, but some babies, they exhibit very critical condition, they come in very critical condition, although the physiological shunts were working even in utero. And so what could be the reason for this? And this is the main cause, because nowadays the surgery has very good outcome and very less mortality is there. But before surgery only, some TJ cases, they actually mortality is there. So what could be the reason in these cases?
Gitanjali, what I can think of, that is what I am telling you, but definitely I would like to know from you also what conditions you are having in your mind. So one of the thing is like the inadequate perfusion at the level of atrial septum. Sometimes there is streaming of blood. So even if shunt lesion is there, but the mixing is not happening.
Yeah,
so, and
yeah, definitely. This is the reason, because of less mixing, even though physiological shunt was open, but not working properly.
The streaming is such that you don't have, particularly in case of a large BSD, so many times people will think, there will be no desaturation.
Yeah.
But because streaming is there, and the second thing is like pulmonary arterial hypertension, that may settle in quite early in the whole thing, and the lungs may not be well aerated, and they may not be functioning. Functionally, the lungs are not good. That is also one of the reason. And severe pulmonary arterial hypertension, which is settling in, or any additional congenital anomaly like pulmonary venous stenosis, one should look for, or any other obstructive lesion on the left side. So those are the things which actually one should look for.
Yeah, definitely. We think that VSD is present, so that is good. But if it is very large VSD, then it is also not good for the baby in postnatal outcome. Definitely. Thank you, ma'am. And I just want to know what type of surgery we usually do in TGA cases.
So that is a good question, because there are two kind of surgeries. The one is arterial switch surgery, and second is the sending operation. So here we know that aorta is committed to right ventricle, and right atrial blood is reaching to aorta, and left atrial blood is reaching to pulmonary artery. So it's a anatomical correction can be done if left ventricle is of adequate size. We should understand that left ventricle is a very delicate organ, but it's a most powerful organ, most powerful pump of the body. So when it is connected to pulmonary artery, which is having a systolic pressure of around 25, and the aorta has around say more than 80, so in that case the LV start getting regressed. The moment baby comes out, the systemic pressure are gone on the LV, and LV just starts getting regressed. In that case, over the 2 weeks or 3 weeks time, this LV is not efficient enough that if you do a arterial switch, that is a anatomical correction. That means you are bringing back aorta to left ventricle and the pulmonary artery to right ventricle. But in that case, the left ventricle will not support aorta and it will fail. So we need to do the arterial switch operation, preferably within 15 days or maybe three weeks. Nowadays, we are doing even later by doing a PA bending and training the LV. And if baby is coming quite late, then in that case, a physiological correction can happen. Like here, you take pulmonary venous blood towards the right ventricle, then right ventricle keep on supporting the aorta, and you take the systemic SVC, IVC blood towards the left ventricle, then left ventricle keeps supporting the pulmonary artery. But in this case, what happens? This thinning of the left ventricle causes LV dysfunction, and the hypertrophied RV getting, because of under systemic pressure, gets dilated, and tricuspid valve then becomes regurgitant. LV becomes very small because of the shifting of interventricular septum on the left side. It increases the LV EDP, and there are chances of malignant arrhythmia. So this is all a complicated process if you are going for sending in at least 30-40% cases. 50-60% cases in that situation also may have a better result. So I'm not talking about them, but still the maximum chunk of the patient will not do well with the sending operation over the period of time, though for transiently for few years they become acyanotic. So because it's a physiological correction, your the pulmonary blood is reaching to system in some other way, which is not very normal, which is not natural. So there is a difference between the physiological correction and the anatomical correction, and anatomical correction recommended better within the 3 weeks of the birth, in a case where the ventricular septum is intact. But even a patient is having persistent PDA without prostaglandin can be delayed up to 2 months, maybe 8 weeks for the surgery.
Yeah, definitely. Whenever there is source of mixing is present, we can delay, but it should not be very delayed. This is the main thing. So nowadays we are preferring to operate early, as you said. Thank you, ma'am. So my next question is to Dr. Leena. As an obstetrician, how will you manage this pregnancy?
Yeah, thank you very much. Very pertinent question. In fact, we had a case like this last year, and it's wonderful when you have a multidisciplinary hospital where you have the help of everyone, right down from fetal medicine to pediatric cardiology to interventional cardiology. When you have everybody around, it as an obstetrician, you feel that you can counsel your patient much better, give her all the options that are there. So we had a patient just like this who was diagnosed at 28 weeks, and the first question they ask us as obstetricians, because we are the ones who are eventually going to deliver her, is why couldn't this have been detected earlier? So this is sometimes something that we need to be good counselors. They should not be a thing that oh, this was not detected there and why was it not picked up there. I think we all need to understand that these are anomalies which by and by, as the baby grows, they open up, and that that comes to light when we have good our radiologists or our fetal medicine doctors, they pick it up. So the first thing we have to do is we've got to counsel them. We've got to tell them that cardiac anomalies are known to pick up only sometimes in the late second trimester, or sometimes even in the third trimester. So you've got to be ready for that. It is very important that we should not add prematurity to the problems that the baby is going to face. So we should try our best to take the patient to term so that the baby is a healthy, good weight, preferably, 2.5. I remember the patient that we had, one of the first things they kept asking us, what is the weight of the baby? And once that baby who also had IUGR, when it crossed 2 kg, then everyone was a little more relaxed, because, planning a surgery for a baby after delivery, when a baby has a good weight and has reached term pregnancy, is always a good point, and it's something you can say in the plus for that particular baby. So follow up your baby, follow up the patient, give her routine antenatal care. Most important, be very empathize with her, have a good approach, be supportive,
and give her the figures. What are the figures? What are the chances for the baby? Discuss with your pediatric colleagues and give her the realistic view. Okay, look, that there will be a surgery that will be required, but this is the outcome. We take you up to term. So in good hands and good setups with a good multi-speciality backup, the results are good. And this is exactly what we did for that one patient. And I'm happy to say that today the child is almost going to be now 2 years old and is doing excellently. So that is my answer, that this is the way we manage the pregnancy. Two things: do not go in for any premature intervention. Try to take her up to term. Address any other problems with the mother, maternal, problems, diabetes, hypertension, as and when do that. Ensure that she has a good antenatal checkup. If she is not able to come like it happened in the last 2 years, well, make sure that you are well connected to her on a video conference. So you manage her just like you would manage any other patient. And most important, be very empathetic and give her the realistic results, the results of surgery, the outcomes with her. Share with her at each and every visit. And most important, right in the beginning, when at whatever period, 26 weeks, 28 weeks, it is diagnosed, be sure not to start the blame game. Always have a very clear idea that these anomalies may not be picked up in the early trimesters.
Thank you, Dr. Leena. So in our case, she is already 26 plus 5 weeks gestation, but at less gestational age, for example, if she is diagnosed at like less than 20 weeks, would you like to discuss the option of termination with the patient?
So yes, that is true. Like I told you, that patient said, I mean, this patient whom I'm talking about, her first question was that had this been detected before, I would have gone in for a termination. Now, you see, while we have majored in cardiac procedures, we have a good setup, we have NICU backup, it's a tertiary care center. But the patient should be very realistic that at the end of it all, a cardiac surgery, a major surgery is there. It is correctable, but with a good success. But having said that, the patient has to, the family, the entire family, both emotionally, financially, they have to go. They have to go the whole hog. They cannot halfway through decide that, okay, this is enough. So whatever be the complications, they have got to be prepared, and they should go with it with a complete, open mind and with all their eyes open. With the current amendment in the MTP Act 2021, it is very clear that we can offer termination to these, for these babies, should the parents say so. So that is very clear that up to 24 weeks, it can be done in all the centers which are already having a license for 20 weeks. And more than 24 weeks after, referring it to the state medical board and taking, the state medical board is there there. And I'm happy to say that it's just recently been constituted in Delhi. So now we can send the patients there, and the state medical board will have a gynecologist, pediatrician, a radiologist, and maybe 1 or 2 other specialties if they feel so. And within 3 days, they give their answer that we can go ahead with a termination or not. Once that answer comes through, we are bound within 5 days to conduct the termination. And that, by the way, after 24 weeks is any time up to term we can go for. But of course, these are decisions that have to be taken on a case-to-case basis with a good discussion with the family. And this is only the legal aspect that I'm conveying to you. And, all these factors may be discussed because, cost after all is something that it's an individual choice, and an individual person has to make up their mind. And not only surgery, they can be the possibility of post-surgical complications, and all of these should be discussed with them to take the right appropriate decision whether to continue or not. And yes, the new MTP Act that way has been, we have been very fortunate that it has come at the absolute right time. So we have moved a long way in this century, and
I think the 2021 amendment is something that's going to really help our patients who've been diagnosed with cardiac abnormalities.
Thank you, Dr. Leena, for such an elaborative answer. So actually for plan of delivery, you have already told us that we can allow the pregnancy to reach till term. So now I want to ask you, suppose if you are not working in a tertiary center, will you allow the patient to deliver at your place, or and will shift to the higher center after the delivery?
So this is true for all complicated pregnancies. You know, the baby is best shifted in utero. So you shift your mother to a center which has the multi-speciality. It is always best in the interest of the baby. So that is very clear. And your delivery route should be guided by the obstetric indication. TGA per se is not an indication for any elective cesarean section.
Thank you, Dr. Leena, and thank you all the panelists for your great input. I hope it is very clear about these cases. Now I would like to invite Dr. Bhavna for the panel discussion of her cases. Thank you.
Thank you, Dr. Gitanjali, and it was a great panel discussion. Now I will be inviting my panelist.
Yeah.
Dr. Seema, you want to say anything about the panel?
Yes. No. The panelist, I think, has been introduced, Dr. Bhavna.
Yeah. Ma'am, is the screen visible?
No, not yet. Not yet. We can't see. Bhavna, we can't see.
Ma'am, is it visible now?
Yes, yes. Make it full screen. And the time, we are running short of time, Dr. Bhavna.
Yeah, I'll be trying to be fast.
Because there is one more lecture left on genetics of thalassemia.
Yeah. So my case one is a patient X. She came, she is third gravida previous to abortion. She came for routine antenatal ultrasound at 12 weeks. No other high risk factor was noted.
Dr. Bhavna, make it full screen.
Yes.
Make it full screen. It's not full screen still.
This one. Is it right, Dr. Nitish?
Yes, yes.
This is better.
Okay. On ultrasound, her CRL was 58.5 mm. Her nuchal translucency was 4.5 mm, which was increased. Nasal bone was present. There was no TR, and DVPI was normal. So there was a risk of carrying a baby with abnormality. So my first question is with Dr. Nitish. What is NT and how to take it?
First of all, at the outset, let me thank Dr. Seema ma'am and Dr. Bhavna for including me in this panel discussion with all the stalwarts. Let's not waste time and start with what is nuchal translucency. So it is sonographic appearance of the collection of fluid under the skin behind the fetal neck in the first trimester. So before we start further, I would like to make 3 important points here. One, term NT is used irrespective whether it is septated or not, whether it is confined to the fetal neck or it envelops the entire fetus. And second point, incidence of chromosomal and other anomalies is related to the size of NT rather than the appearance. And in the second trimester, usually the NT resolves. However, in few percentage of the patients, it evolves into nuchal edema or cystic hygroma with or without hydrops. Now, this slide shows the checklist to take the correct NT. As we all know, it should be taken by an experienced and certified sonographer who has had a regular quality assessment, good ultrasound machines, Transabdominal, transvaginal scan can be used. Gestational age should be accounted between 11 to 13 weeks, 6 days. Magnification should be such where the entire where the screen has the entire screen has the upper part of the thorax and the fetal head. Mid-sagittal section should be taken. Neutral position where there is fluid between the chest and the chin. Maximum measurement of the nuchal translucency should be taken. It should be differentiated with the amnion. These things we all know because we have been taking this regularly. Now, in euploid fetuses, normally the nuchal translucency increases with crown up length. For example, at a CRL of 45 millimeter, the median would be 1.2 millimeter, and this would increase to 1.9 millimeter at the CRL of 84 millimeter. In contrast, when Dr. Bhavna, next slide, please. In contrast, when the NT is more than 3.5 millimeter, that is above the 99th centile, it does not change with CRL.
Yes, very rightly said, Dr. Nidish. Thank you for your inputs. My next question is with Dr. Yogita. What are the abnormalities related to increased NT? Is she there? So abnormalities associated with increased NT, maybe chromosomal defects, cardiac defects, diaphragmatic hernia, exome failures, body stock anomalies, skeletal defects, and certain genetic syndromes. There may be n number of causes, and these n number of causes with rare disorders are all listed in the FMF website, in which when we click over some disease, they will this will expand and give a detail about that disease, so that we can be more enlightened. And the ones which have a star on it means that they have prenatal diagnosis available. So what is the mechanism of increased NT? Again, it is similar as we have discussed previously in our lecture about the hydrops. It may be cardiac failure, venous congestion, or alteration of extracellular matrix, delayed development of lymphatic system, failure of lymphatic drainage, anemia, or congenital infection. So my next question is with Dr. Prerna. What is the relation of abnormalities with increased NT?
Thank you, Dr. Bhavna. Yeah, thank you, Dr. Bhavna, for inviting me here. I'm more of an IVF consultant, but the limited thinking which I have about NT is like NT is basically, it's a continuum, as Dr. Nidish told us about. It basically depends upon the gestational age, and as the CRL increases, the NT increases. But the 99th centile remains 3.5 mm. So any NT with more than 3.5 mm, the prevalence of abnormalities greatly increases, and in a patient who has a low gestation and a high NT, it might. So any NT more than 3.5 mm, you have approximately 20% abnormality, risk of 20% abnormality. And that's why there is an indication for these increased NTs to be investigated. But even with 20% abnormalities, 80% fetuses are going to be normal. So we need to find out fetuses which are normal, which are euploid in patients with increased NT also.
Yes, Dr. Prerna. So when we have known that this baby may be normal or may be abnormal, how to manage patients with increased NT? My next question is with Dr. Nidish.
Thank you, Dr. Bhavna. The aim of the management is actually distinguishing the fetuses who are likely to have abnormality from those fetuses who are likely to be normal, and as quickly as possible. So the management of the fetuses with increased NT has been classified into two subgroups depending upon the NT value. When the NT is above 99 centile, that is above 3.5 millimeter. And when the NT is below 99 centile, that is less than 3.5 millimeter. So talking about the first subgroup, when the NT is above 3.5 millimeter, which is found in 1% of the pregnancies, the risk of chromosomal abnormalities is very high. So after performing a detailed early anomaly scan that between 11 to 13 weeks, 6 days, the first line of management of such pregnancies should be to offer a CVS for fetal karyotyping and microarray. Now, if the microarray and karyotyping is normal, then fetal echocardiography along with a detailed scan is again performed at 14 to 16 weeks, and which is again followed by a detailed anomaly scan at 20 to 22 weeks. Now, if these investigations in the subset where the NT is high and NT is resolved for around 14 to 16 weeks, then parents can be confidently reassured that the possibility of adverse outcome may not be higher than what is there in the general population. Now, in the same subset, when the NT was higher, that is more than 3.5, and it is persisting at 14 to 16 weeks, and the nuchal edema is developing with or without hydrops at 20 to 22 weeks, then the possibility of congenital infections or genetic syndromes should be kept in mind. Now, there is a role of whole exome sequencing in such scenarios, and it can yield up to 32%. It can result in 32% of the individuals, and in those patients where the microarray was negative. But because of certain ethical and economical issues, it has not been incorporated in the management of the floats and the management of these increased NT fetuses. Now, maternal blood should be checked for diseases such as toxoplasmosis, cytomegalovirus, parvovirus B19, and follow-up scan should be performed every 4 weekly to define the evolution of the edema. Then DNA testing can be performed for certain genetic conditions such as Noonan syndrome, even if there has been no family history. Now, even after performing all this, there is chances that 10% of the fetuses will have parental death or genetic syndrome. That could not be diagnosed antenatally. 10% risk of evolution to hydrops, and 3 to 5% risk for neurodevelopmental delay in the survivors. Dr. Bhavna, next slide, please. Now, in the second subgroup, when the NT value is below 99 centile, that is less than 3.5 millimeter, the decision by the parents to go for fetal karyotyping by CVS, that will depend upon the patient-specific risk. That again is based on maternal age, ultrasound findings, and free beta HCG and PAPE. Now, if the risk is high, fetal karyotyping can be offered, and there are chances that 97% of the individuals will have normal outcome. So detailed anomaly scan can be performed at 20 weeks in such fetuses. Now, if no obvious abnormalities, then these parents can be reassured that the baby is likely to be live born and develop normally. The chances that there would be any problem are not higher than what is there in the normal in the fetuses with normal NT. Now, these last 2 slides, we have tried to sum up whatever management we have been talking about. Now, the patients can be subdivided into 3 risk groups depending upon the maternal age, fetal NT, fetal heart rate, free beta HCG, and PAPE. Now, high risk group individuals are those who have risk more than 1 in 50, and these are the population where the chances of trisomy 21 would be the highest. They have to be offered coronary villus sampling and karyotyping and this microarray. Now, low risk people, those population in which the risk is less than 1 in 1,000, they can be reassured safely that fetus is unlikely to be affected, and followed by detailed sonography at 20 weeks. Now, intermediate group is the one where the risk is between 1 in 51 and 1 in 1,000. And there is the role of assessment of new markers, which now we usually do in all the patients. That is the nasal bone, ductus venosus, and the tricuspid regurgitation. And then they can be reclassified into high risk group and the low risk group. The high risk group can be offered coronary villus sampling, and low risk group is the population where there is role of NIPT, and then they can be, if the result is normal, they can be followed up at 20 weeks again with the detailed sonography and echocardiography. Dr. Bhavna, next slide, please. Now, to sum up, this is a simple flow chart which will help us in counseling as well as managing the fetuses with increased NT. So a detailed scan is performed at 11 to 13 weeks, 6 days, followed by coronary villus sampling. If we find any abnormality, chromosomal defect or major abnormality, then the parents can be deciding for the termination. If it is normal, no normal karyotype, no other abnormality, then another detailed scan is performed at 14 to 16 weeks, along with fetal echocardiography, which obviously would be difficult at this gestation. And then there can be 3 possibilities. 1, there can be major abnormality in fetal death. Secondly, there is no abnormality in normal NT, and these fetuses can be again followed up at 20 to 22 weeks with detailed anomaly scan, fetal echocardiography, and no abnormality. But a third subgroup where there is no abnormality, but there is high NT edema has developed with or without hydrops, then these are the population where infection screen and genetic testing has to be performed. And as I've already shown in the previous slides, and if there is major abnormality of fetal death, then accordingly can be managed. Thank you,
Dr. Nidhi. Thank you for this descriptive management of increased NT. Although everything is available on the websites and internet, but it is to incorporate these things in our routine practice so that no patient is missed or no abnormal baby is born and no normal baby is aborted. Thank you. So in our case, how did we manage our case? Dr. Yashika?
Yeah, thank you, Bhavna. Dr. Nadish has already explained completely. So the same way we managed our cases, we consulted our patient and the patient agreed for a CVS. CVS came out to be normal. And then the couple was reassured and was asked to come at 16 weeks for the early anomaly scan. And anomaly scan with cardiac anomalies was done. And nuchal fold thickness came out to be normal. Level 2 was done. And then the fetal echo at 24 weeks was done, which came out to be normal. So the rest of the pregnancy went off uneventfully, and the patient delivered a healthy baby at 39 weeks. So what was our conclusion? So we all know that NT is an expression and is usual marker for the chromosomal abnormalities and fetal malformations and genetic syndromes. But the chance of an uneventful pregnancy outcome is inversely related to the initial degree of enlargement. So what we have seen, if the NT is more than 3 mm, so there is a 43 to 75% adverse outcome. And if it is more than 5 mm, 75% chances of adverse outcome in there. So along with the increased NT with additional anomalies, there is more than 60% chances of an adverse outcome. And I will say it is not in 60, it's more than that there is a high chance that there might be some abnormality. So with increased NT, we all know the chances of trisomy 21 is high. And seeing the PAPI and beta HCG, we will come to a conclusion which further testing to be done to the patient, a proper counseling and a proper investigation and follow-up of the patient. And after the 24-week option for termination, we can obviously take the patient beyond 20 weeks with even if we have a mild doubt of any anomaly or cardiac anomaly, and take a termination later on also, if there is a major cardiac anomaly.
Very true, ma'am. Very rightly said. Thank you so much, ma'am. So our next case will be was our patient X. She was 28-year-old, second gravida, live 1. She came at 20 weeks gestation for first antenatal visit and for routine checkup. Her blood group was O negative. Husband blood group was B positive. She has not received any anti-D in her previous pregnancy. And beside routine investigation, ICT was performed, which was positive. So what is the risk to the unborn fetus and how does it happen? Dr. Vinay.
Right, ma'am. So this is gravida 2 pregnancy and she has not received, she is already ICT positive. So there is a, higher risk of nearly 1/3 to 1/4 type of, babies are going to be having, either some sort of hydrops or having, early bilirubin encephalopathy.
How does it happen, Dr. Vinay?
So if mother is RH negative and if the husband is RH positive, so and chances of having RH positive fetus is very high. And during pregnancy, especially during last trimester of pregnancy, there is some kind of feto-maternal hemorrhage. So the fetal red blood cells, fetal RH positive red blood cells enters into the maternal serum, and which is detected as a foreign antigen. So mother start producing antibody against the fetal RS positive antigen. And initially, as we all know that the antibody is IgM type. So later on that after 5 to nearly 4 months of sensitization, the IgM antibody converted to IgG antibody, and this antibody crosses the placenta in the next pregnancy and causes destruction of fetal RBCs. So this is a very rare condition called erythroblastosis fetalis, and in almost all of the cases, especially in developing countries where giving anti-immunoglobulin is not so much common, this is exclusively because of RH incompatibility. Minor blood group antigen rarely causes erythroblastosis fetalis, and it is because of maternal antibody causes extensive hemolysis of fetal RBC and leads to anemia, which causes high cardiac output failure and then liver dysfunction and capillary leak, which leads to the hydrops fetalis. So the pathophysiology of isoimmunization is RS positive fetal cells, as I told previously also, enter into RS negative maternal circulation, either because of previous abortion, or mother has received Rh positive blood, or because of some kind of mother has not received adequately anti-D immunoglobulin, so she develop antibodies against the fetal Rh positive red blood cells. And this antibody, IgG antibody, enters inside the fetal circulation and coated with the fetal RBCs and causes destruction of this RBC inside the spleen. So leads to the extra hematopoiesis like splenomegaly, hepatomegaly, and during fetal life, this causes anemia, which leads to hydrops fetalis. And after birth, this leads to bilirubin-induced neurological dysfunction, acute bilirubin encephalopathy during immediate neonatal period, and later on, after 6 months, 1 year of age, leads to chronic teres, which is called nowadays as a chronic bilirubin encephalopathy.
Yes, very true, Dr. Vinay. Thank you for this beautifully describing in detail the pathophysiology.
Thank
you. Does it always due to Rh-D antigen?
So in most of the cases, nearly 97-98% of the cases, it's because of Rh positive blood cells, but in some of the cases, and nowadays because of frequent use of anti-D immunoglobulin, some minor blood group like C, E, KIL, or E antigen also can causes erythroblastosis fetalis. But in that case, ICT in the mother will be negative.
Yes, yes. So what is the prerequisite for developing an Rh-D alloimmunization in a mother?
So the most important thing is the fetus should be Rh positive. So only in that case, and even fetus is Rh positive also, not all mother develop anti-D antibody, because of it's also depends on the antigenicity of the fetal red blood cells, the immunological response by the mother, and the compensatory response shown by the fetus if the maternal antibody transfers to the fetus. So it's not only because of presence of the antibody, but because of some other factors also. It's depending on the expression of that antigens on the fetal red blood cells, time of exposure, compensatory mechanism activated by the fetus, and some unknown mechanisms too.
Yes, very true, Dr. Vinay. Thank you so much.
Thank you,
so how to prevent this condition, Dr. Yashika? Can you enlighten us?
Yeah. Bhavna, there we have two types of patients. So first one is one in which who is a primary gravida and who is still we have to prevent her from having an Rh alloimmunization. The other patient is who has already been pregnant or has an abortion, and where if she's already immunized, we have to manage those patients. So there, obviously, as a doctor, our first priority should be to prevent Rh alloimmunization. So we will start with preconceptional counseling. I think whenever a patient comes to us in a for a counseling, that time also we should know what is the blood group of the husband and wife, and at that time also we should, because that is the first opportunity a couple is getting with a doctor. Because I have seen lots, and nowadays we know most of the patients know their blood group and the husbands know their blood group, they are taking anti-D. But what is happening due to many reasons, IVF conceptions, IUI, many times the patients get conceived, there is a pregnancy of unknown origin, the beta HCG was little raised. Sometimes they say in those conditions there is no negligible chance of exchange, but there are still, we see that in those cases also sometimes patient is not aware, they have taken medical abortion at home and they can become positive. So there we have to always teach our patients from the first visit onwards that please be aware, if you are negative, if you are positive and you are negative and your partner is positive, you should take an anti-D even if you are taking medicine at home. So that is the first step. And in every pregnancy, first anti-D, do the blood group. We all do it. Only in rare cases it has happened, the patient has forgotten her blood group. So we always ask whether you have taken a costly injection or not. So that is the way we ask the patient. If Rh negative and the husband is Rh positive, woman Rh positive, but with history of blood transfusion and unexplained fetal losses, and infants, the death of infants has happened with jaundice, we should always go for an Rh antibody testing. So, and there we can know whether something like this has happened earlier or not. And Rh antibodies are tested by direct, we do the ICT test. So in that way, we can always prevent. If doubt, we should always do the anti-Ds in the first trimester also when the patient visits you first time. Otherwise, we do it at 20 weeks, at 24 weeks, and 28 weeks. So that is the time. So this is a chart by which prevention can be done. So we know when the ICT is positive or negative. So if it is negative, nothing needs to be done. If it is positive, then we have to along with our radiologist, we have to go for a regular screening of the patient, and we have to inform the patient that things can go wrong, and we have to take an early decision for delivery whenever required. If the patient is negative, we give an anti-D at 28 weeks. If the patient is already positive, then we go according to the titers. We go for the titers. We do the titers. It should be less than 1:4, but till 1:32, it is a lot high risk. So we can manage accordingly, according to the ultrasound reports. And anti-D 300 should be given. If the patient has an episode of bleeding before 20 weeks, anti-D 150 can be given. And after that, we should give a 300 anti-D after 28 weeks. If ICT is positive, concentration should be determined by titration. We have already talked about this part. Next. So antibody, so if less than, we have talked about this part, yes. So I think we have already talked about this part. So just nowadays, what has happened, few of the cases I discussed with Bhavna and Gitanjali, that they came to us, and we did a ICT, or the patient got an ICT positive report to us. And that report was positive because the patient had taken an anti-D, and then she came to us and that was positive. So we should always be sure that patient has not taken an anti-D recently and then come out with a positive report of the titer. So we should be careful with it.
Yes, very true, ma'am. Very rightly said. Thank you so much. Then if the pregnancy become isoimmunized, then how to manage that case? Dr. Nidhish?
Thank you, Dr. Bhavna. So the aim of the management is to predict whether the fetus is anemic and to correct moderate to severe anemia by intrauterine transfusion or timely delivering the baby depending upon the gestation. So the management of isoimmunized pregnancy is based on middle cerebral artery peak systolic velocity assessment. So the simple physics is peak systolic velocity of the blood moving through the various fetal vessels has been investigated as a method of determining when the fetus is going to develop anemia. So this concept is based on the fact that the fetal blood velocities become elevated in response to increase in the cardiac output and decreased blood viscosity in the anemic fetuses. So if ICT becomes positive anytime during pregnancy, then middle cerebral artery peak systolic velocity becomes a very sensitive and specific marker for fetal anemia, thereby replacing the need for amniocentesis, which was done earlier, now probably no longer practiced. Now, in this slide, what we have tried to show is how do we take middle cerebral artery peak systolic velocity. So for technically inclined people, it is basically after taking a axial section of the fetal head, then color flow is used to locate the MCA over the anterior wing of the sphenoid bone. Doppler gate is placed in most proximal portion of the middle cerebral artery. Angle of insonation is kept 0 degree and measurement is taken at least 3 times. So after taking the measurement of peak systolic velocity, it is plotted against the gestation age. So if it falls above 1.5 mom, then this indicates moderate to severe anemia, thereby requiring confirmation by chordocentesis and assessing the hematocrit, and thereby followed by transfusion. If it is between 1.29 and 1.5 mom, it has to be followed, repeated after every 3 to 5 days. If it is below 1.29 mom, that is to be followed within 7 to 10 days, and below median value, then it can be followed up within 2 to 3 weeks. Dr. Bhavna, next slide. Now, the maternal titers have to be followed every 4 weeks, up to 24 weeks of gestation, and then thereafter they can be repeated 2 weeks after every 2 weeks. Now, once the critical levels have been reached, that is more than 1:8, then fetal testing for prediction of anemia by middle cerebral artery peak systolic velocity is indicated from 18 weeks onwards, and MCA PSV assessment has been found to predict the presence of moderate to severe anemia in fetuses with a sensitivity of nearly 100% and a false positive rate of 12%. So if MCA PSV is less than 1.5 mom for gestation age, follow as I have already told. And if it is more than 1.5 mom for gestation age, chordocentesis is done to detect the fetal hematocrit. And once the severity of fetal anemia is diagnosed, then the logical treatment would be intrauterine transfusion. And fetal hematocrit, if less than 30%, it becomes the critical.
What happened in our case? Our case was ICT positive. It has a titer.
I have joined.
Oh, sorry, Dr. Yogita.
No problem.
Please, Dr. Yogita, go ahead with what happened to our case.
Yeah, Dr. Bhavna. So thank you, Dr. Bhavna, for giving me the opportunity and involving me in this panel discussion.
And
As
thank
we
you,
can
Dr.
see,
Yogita, to spare such a time in your busy schedule for taking the talk. Thank you.
Thank you so much. Yeah, so as we can see, in our case, ICT was positive with titers of 1:16. As we can see, it falls in that critical value. So it was followed up very carefully with serial ultrasounds. NCA PSV was done. And we also did the ultrasound to detect whether there is any feature of fetal anemia, if there is any fluid collection, if there is any feature of hydrops fetalis. NCA PSV was done and it was found to be less than 1 MOM till 34 weeks. That means till that time we were safely reassured that the baby has not become anemic. But at 34 weeks, the NCA PSV had increased to 1.5 MOM, which again indicates that now the critical levels have been reached and the decision had to be taken of delivery versus chordosynthesis, which has been, just now been described by Dr. Nidesh. Now, as you can see, we had already reached 34 weeks. So we decided upon delivery of the baby. Betamethasone cover was given. LSCS was done in view of breech presentation. And we delivered a healthy newborn with a birth weight of 2.4 kg, hemoglobin of 13.2, cord blood bilirubin was 2.21, and direct Coombs test was positive. So there was no need of any exchange transfusion. Baby just had mild jaundice. And so we can see that in this case, we had successfully managed the pregnancy and we had a healthy mother and a healthy baby.
So what was your conclusion, Dr. Yogita?
See, as we can see, okay, these pregnancies, isoimmunized pregnancy, they can be very critical also, but if they are followed very carefully, good ultrasounds can be done at multidisciplinary center with the help of fetal medicine experts and careful monitoring of the patients who are isoimmunized, the MCA-PSV, if it is done, and features of hydrops, they can be detected at correctly. So we can manage these RH immunized pregnancies in in a better manner and good results can be taken home. So it is a preventable condition with a careful antenatal follow-up.
Yes, very true. So RH isoimmunization is a preventable condition and every effort should be taken that patient should not get isoimmunized, and even if isoimmunized, full treatment is available. With this, I stop this panel discussion. And thank you so much all the panelists and all the organizers for giving us the chance and for such a beautifully organized sessions. Thank you so much, Dr. Seema, for giving us
wonderful panel discussion, both Gitanjali and Bhavna. We thoroughly enjoyed. I would expect some inputs if Vandana is free now. Vandana? Okay. So I think CPAM, long ago, many a times I get for the CPAM, one line I would say that there is no need of termination. The condition can be well managed. Then regarding the RH isoimmunization, the key message is prevention is still, though we have IUT available, but still we have to aim for the prevention so that this does not happen. And these are the two important messages which I want to highlight. Regarding the NT, so increased NT is not an indication of termination of pregnancy, because most of our colleagues, the moment they find that this is increased, that they would terminate. Rather, it is an indication for further workup to identify which fetuses actually have problem and which need termination. And if the NT resolves, and at level 2 scan and there are no other abnormalities on the baby and the microarray is okay, the outcome is as good as the normal population. We cannot expect that the 100%, but yes, the developmental delay, the risk is quoted as same as the general population. So these are 2-3 important points which I wanted to re-emphasize, though you have covered very well. So with this, anybody wants to comment? Dr. Nidesh, Dr. Smita?
Yeah, I would like to, because there was a question from Dr. Shalini Agrawal and I wrote the answer. Did she read it, Shalini? Dr. Shalini?
The tertiary care, yeah, you answered.
Dr. Shalini?
I think she has left, but I think the question is pertinent. What she asked is
But
important.
the question is pertinent in a remote area. If you are sitting and getting a congenital heart disease and the parents are saying that we are not going to opt for a surgery or intervention for the this congenital heart defect, you just do the delivery, either CS or whatever way, and just leave it like that. So here the one part is about the obstetric care, and that probably cannot be denied because the mother's life is at stake. And so proper conversation, counseling, referral is needed if you want to, if it can be done. Patient can be referred for a multi-specialty place with the all counseling session recorded and documented. And the second thing is, if it is not possible and the transfer of mother is not possible, in that case, the obstetric care should be provided. Baby should be kept in an ICU, should be given all the information. And if they want to take a patient to probably Dr. Leena, if she is there, she can add up, Dr. Vinay. The patient can take baby Lama. We cannot actually do much into that if parents don't want. We can only refer that baby to some place because the hospital is not well equipped for doing any that kind of surgery. But in this particular case where TAPVC was detected, usually total anomalous pulmonary venous drainage, patient remains, the saturation remains around say 85-90. So they survive quite well in first 4 to 8 weeks. So it's not a immediate surgery most of the time. So you can deliver and you can give the proper, so there this detailed analysis is very important. What is the diagnosis? Is it a obstructed kind of TAPVC or unobstructed kind of TAPVC? That is one thing one should know. The second thing is, if it is a obstructed variety, then actually you have to operate within few hours. It's not 4 to 8 weeks, but rather not even 4 days. It may be 4 hours. So this is that much emergency. So that has to be explained and is parents' choice, because once the baby is born, I think baby and mother, they are two separate patients. So obstetric care, Dr. Seema, you can definitely make one comment that obstetric care, you cannot deny a patient if mother is in emergency, but if you can refer, you can definitely refer.
So at least they should document everything.
Our documentation is very much important.
That they have been offered, but the patient doesn't want to,
and the written thing and all those things. It is our responsibility, whatever we are doing.
Yeah. So later
but
on,
I think obstetric care can, the crux of thing is, if mother is in dire need of cesarean, like emergency is there, then obstetric care should not be denied.
Yeah, that is true for any emergency care that you have to. Yeah. So
thank you,
I think Vandana has joined. Vandana?
I think little bit I missed some of the parts, but what is interest is I think you want me to comment on the RH negative part.
Yes.
Right. Yeah. So I think the crux is the prevention. We have been talking about that we don't want the RH isoimmunization to happen. We want to prevent it. And most of the panelists have emphasized on the importance of prevention, the correct identification of clinical situations where we might end up with an isoimmunization. So even in the first trimester, the kind of like if we do a CVS, we need to give the anti-D and early identification of a hematoma so that we can so on. And we also have intrauterine fetal transfusion now available, which is a very successful fetal therapy, and done in the correct indication and setting, we can give a good result to the patient.
Even the hydropic ones also.
Yeah, even
I remember one of our cases which had hydrops, and then now the child is about 10 years. So you did the fetal transfusion.
Yeah,
I
that was
referred to you.
12 years back, I think we did it.
Yes. So now the child is doing quite well. So
we have I think it is a success story. We have quite a few patients where even in hemoglobin 2 and hemoglobins like 1.8 and 2, we have done transfusion, and there has been no neurodevelopmental delay, except one patient where I remember there was a cerebral palsy and the watershed area of the brain was showing us infarcts after birth. All the other patients have really done well in the ones that we have managed.
Yeah, this is one of the most successful, part of the intrauterine treatment, where it is, the results are almost near to more than 90%. So I think with this, we thank you, Vandana. So with this, we move on to the next session. So this is for the genetics of thalassemia. And for this, we have from the sponsors team, that is Dr. T. Senthil Kumar, who is the Scientific Affairs Manager, MedGenome Bangalore. He is an application scientist for genomics, NGS, microarray, and he is an experienced professional in the domain of his CV. Himanshu, Shivam? Yeah. So he has worked in the laboratories handling NGS library preparations and operated NGS sequences of both Illumina and Ion Torrent. So he's basically a scientist working in the field of the molecular genetics. And so welcome, Dr. Senthil. So now you can begin your slide share.
Good evening, all.
Good evening.
Just a minute, I will share the screen.
Yeah, sure. You can be brief because we have already passed the,
Yes, understandable.
And crisp.
Yeah,
just 17 slide. Okay, that is perfect.
Sure, yes, I will make it short because already Dr.
No, 17 is okay. 17.
all right.
Go at your own pace.
Yeah. Thank you very much, Dr. Simataku ma'am and Dr. Kiranjali ma'am and team AOGD for giving MedGenome as an opportunity to participate in this CME. So I'm presenting here on behalf of Dr. Priya, who was supposed to present here. So
yeah.
Yes. So community genetics in India. So India is a hotspot for studying genetic diseases. So as you might know from the literature, there are 7,000, listed inherited genetic disorders. And India is the most populous country where consanguinity is high. So they are referring India as a hotspot for the genetic diseases. Although there are individually, they are rare, but collectively, cumulatively, the kind of burden, genetic burden it creates is quite a lot. So already we have discussed about beta thalassemia, for example. In down south, we see a lot of these neuromuscular disorders. Actually, in north, it's more of anemic conditions. So we can see even for all other rare disorders also in India, we might see at least 1 or 2 cases. So that much genetic burden is there because of a lot of consanguinity issues in India and other Southeast Asian nations. So that's where the MedGenome is a genomic service provider operating over the period of 10 years we are operating. And then the strength of the MedGenome is that kind of the reference database, Indian ethnicity population related database we have created over the period of time. As you see, when it comes to reporting these genetic variants and all, again, there is a lot of ethnicity involved. Like whatever the databases we have seen from the world is more correlating to, Caucasians, European populations and everything. So that's where we need to sequence more and more Indian ethnic or Asian ethnic populations to understand more and reporting more clinically relevant variants. So MedGenome has participated in a lot of consortium genomics projects along with other countries, and we have done this 100K genome project and all along with Singapore and China, and we have created now our own internal reference database so that we can, very clinically relevant variants can be reported. So this field is very evolving actually. So more we sequence and more the literature becomes available, the more the accurate the genetic diagnosis it's become. So that the diagnostic yield will increase. Right now, it may be put it across like 40 to 50% by doing whole exome sequencing or clinical exome sequencing. It is bound to increase as we do more. The database is the key here. The data is the wealth here when it comes to genomics. So I will quickly come to the topic of the today, which is beta thalassemia genetics testing. So here I will focus more on, I mean, Dr. Giranjali ma'am has given a wonderful talk on the clinical indications and the management aspect and everything. My talk will try to focus more on what kind of genetic testings we can go for. So I will project on that. So the thing is that when it comes to beta thalassemia, it is absence of the beta globin gene or abnormal expression of the beta globin genes. When it comes to alpha thalassemia, it is HBA1 gene and HBA2 gene, which might leads to very well discussed already previously, that HPH and Hydrops fetalis syndromes. And in HBP gene, the other variants, there are a lot kind of variants can happen in the entire HBP gene. So accordingly, it will be diagnosed as sickle cell or HBE form or C or D. So when it comes to genetic variations, there are broadly classified into two different forms, which is single nucleotide variations and copy number variations. Again, these single nucleotide variations can be of single base substitutions like G to C or A to T, or one base pair deletions or insertions. So the top panel is the reference sequence and the bottom one is the test sample sequence. So we are always aligned the reads to the reference, human reference genome, and then we will study what kind of alternate alleles present in the test sample. So it could be of substitutions, or it could be of deletion, or it could be of insertion, so which is less than 1 kilobase per resolution. So we call it as SNBs. So when it occurs over the span of bases, nucleotide bases, we will call it as copy number variations, which could be of copy number gain as shown here, or it could be of copy number loss as is shown in the second panel, or it could be of even the translocation. So all these things called as structural aberrations. So when it comes to test methodologies, so when it comes to HBP gene, beta globulin, for the point mutations, we always go for NGS based sequencing, mean sequencing the gene for the single base pair resolution level. So typically we need to do for these conditions like when you diagnose, clear diagnosis goes towards beta thal or sickle cell or HBE, HBD forms. All these things caused by the point mutations in the beta globulin genes. Where the variant is occurring, accordingly the condition is the phenotype. So very rarely when the delta beta thalassemia conditions in the beta globulin gene, some deletions, duplications may be the reasons. So that time your NGS sequencing may not be a correct diagnostically yielding method. That time we recommend you to go for MLPA, which is abbreviated as multiple ligation dependent probe amplification, where we look at particular exonic deletions or duplication event occurred or not. So this generally occurs in the clinical diagnosis of delta beta thalassemia or the fetal hemoglobin presence. So this is with regard to beta globulin gene mutations, where we offer next generation sequencing and MLPA. So when it comes to alpha thalassemia related, where the alpha globulin genes are involved, which are called as heterodimers like HBA1 gene and HBA2 genes. Here again, when it comes to alpha thalassemia, mostly we see, unlike beta thalassemia, where point mutations are reported more. When it comes to alpha thalassemia, deletions and duplication events are also reported more as per the literature. So here we recommend for deletion duplication analysis, we suggest you to go for MLPA. And when it comes negative, diagnostic yield comes negative, and still you are clinically diagnosing alpha thalassemia, and to confirm it in the differential diagnosis by genetic testing, we recommend you to go for alpha thalassemia, HBA1, HBA2 gene sequencing, whole gene sequencing. So all these things together is called as comprehensive thalassemia panel. So this includes all the above tests. So you can always opt for the specific test based on your clinical diagnosis at your clinic. We can opt for the specific test, or if you have the more broader anomalies and multiple things possible, then we can go for comprehensive thalassemia panel. So as I mentioned earlier, HBB gene testing. So what at MedGenome we are offering 100% coverage of the HBB gene, including promoter, exon regions, intron regions, and upstream, downstream regions. We have developed specific sequencing, NGS-based sequencing method for HBB gene alone, so that not to miss any novel variants which are identified in any different kind of populations, rather than going for the hotspot mutations they will see. They will study only the hotspot mutations, not the full gene. But at MedGenome, we are offering HBB full gene sequencing, and also the common deletions. Reported one is the 619 base pair deletion in the HBB gene. Our comprehensive beta thalassemia panel includes this above HBB gene sequencing by NGS method plus the MLPA. In case the NGS may not detect your exonic level deletions and duplications. So when you go for comprehensive gene sequencing plus MLPA, so our diagnostic yield potential increases. So same way in alpha thalassemia also, we are offering both gene sequencing and deletion duplication analysis. So the test method, when to go for what test regarding this, as discussed in the previous speakers, the HPLC findings and CBC count is very, very important. That's the first line of clinical diagnosing. And then to do the genetic testing to confirm that, we are going for the genetic testing. So beta thalassemia, delta beta thalassemia, we'll go for MLPA. In alpha thalassemia, we'll go for sequencing and MLPA. So the HPLC reports of the both the partners should be studied well before to go for optimal genetic testing procedures. So that is must anyway, we can't skip that, as discussed by Dr. Gitanjali ma'am. Coming to common mutations versus HBB gene sequencing. As I mentioned earlier, the complete sequencing of the HBB gene analyzing is very, very needed rather than going for this hotspot mutation identifications. So from our MedGenome's internal reference database, we identified at least 15 to 20% of cases where we identify uncommon variants than what is already previously reported in the literature many times. So sometimes so few variants may be specific to some families, occurring in some some clusters, few clusters in certain specific regions, where what we call the founder effect kind of things. So those kind of novel variants identification is possible by the full-fledged comprehensive genome sequencing of HBB gene. Just to highlight on the importance of those things, so we are showing one case study. So if you see in this case, in the partner, male partner, we have identified one intronic variant we detected, which is done in some laboratory. But in the wife, they did not, they went for the testing for the common mutations, which was not detected actually. So only in the father, they identified some specific variant detected, but this is not the comprehensive test. So again, in the fetus, they have detected the whatever the variant they have seen in the father, that is that in this particular intronic variant, as we have seen here. This variant was identified in the father, the same variant they identified in the mother, but they could not diagnose it's detected, but they could not conclude whether it's a beta thalassemia minor or major, but the child born affected. So the missing link here is that we should have identified the carrier mutation in the supposedly identified in the mother. So what happened when the child, when we did the prenatal testing for this particular case, so we have actually seen, along with this intronic variant, we are seeing one heterozygous deletion also actually. So this is possible only when we do the comprehensive testing of HBB. Otherwise, if you do only point mutation related testing, we tend to miss. This is one case it happened to be actually. So, but the child born affected actually. So the fetus is affected with beta thalassemia because of these compound mutations, two mutations. One happened to be inherited from father, which was detected by the normal method, but the other one inherited from the mother, which was missed out, was this heterozygous deletion mutations. So this is the advantage of going for the comprehensive gene sequencing, which we would like to highlight and which MedGenome offers for the thalassemia, comprehensive thalassemia panel testings. Coming to another case study. So whenever we go for prenatal testing of thalassemia, the carrier testing is very, very important and must. So then only we'll come to know where to look at in the prenatal cases genetic testing, exact that gene locus. So we need to must identify the, so in this case, if we see no pathogenic variants were identified in this case study. So PND cannot be offered as father's mutation is not known. So we could not detect any mutation in the father case, So it is very difficult to suggest correct method for the prenatal testing for genetic diagnosis. So the carrier testing is also very, very important before going for prenatal workup for the thalassemia cases. So we need to do all possible genetic workup we need to do. If one method comes diagnostic yield negative, we need to opt for other. Is there any deletions was present? We need to conclude that clearly before we going for prenatal testing workup. So this we would like to highlight. So this is our short take-home message. The history of the family history is very, very important, and we need to go for the HPLC report and CBC count. So clinical work is very, very important. Once that data established, then comprehensive testing should be considered. As we have shown in some of the case studies, sometimes we tend to miss some key genetic variants if you go for the routine normal hotspot mutation testing. So with the advent of these NGS-based techniques, now we are scanning entire gene region, including some intronic regions, flanking intronic regions, and upstream promoter regions and everything. So the variant can occur at any place actually than the commonly reported literature-related variants. So when the carrier testing should be done, that's also important. When it's a prenatal cases, so the timeline is very, very less. Quickly we need to identify. That time we are suggesting to go for quick trio analysis at once. If ideally the carrier testing workup should have been done, and accordingly the variant we need to look when it comes to prenatal cases. But when the time is short, we need to make a quick decision. So that time we are suggesting to go for quick trio analysis of father, mother, and fetus in question, or the previous affected sibling also can be tested to understand the segregation analysis and how the variant is inherited in the family. So, and then as mentioned, as highlighted and insisted by our previous speakers, genetic consultation and counseling is key when it comes to genetic testing, offering to the autosomal recessive disorders and convincing the parents accordingly to take informed decision makings. Thank you.
Yeah. So thank you, Dr. Senthil. You have done very clear messages that, you know, the basic difference between the alpha thalassemia and the beta thalassemia is the type of mutation. That in cases of alpha thalassemia, it is the deletion duplication in more than 2/3 of the cases. Yes. And in beta thalassemia, it is the point mutation. And that's why the strategy for testing both of them differs. So tell me, by comprehensive analysis, what do you mean? That is both the beta globin gene sequencing plus MLPA.
So comprehensive beta thalassemia panel does point mutations for HPP gene, entire coding region we are scanning, plus MLPA. And then comprehensive alpha thalassemia panel means MLPA for HBA1 gene, HBA2 gene, plus gene sequencing in both the genes. Now,
but by this you will not detect the ATRX case, which we detected last time.
Yes, ma'am. Yes, ma'am.
Yeah, you will not detect. Okay, so
yes.
if you still, then you would offer the whole exome sequencing.
Whole exome sequencing.
Yeah?
Yes, I got that point, ma'am. Even while talk, I heard that. I noted that point also.
Yeah, and one thing which you said that in one case there was only one mutation identified in the parents, and you said that the PND cannot be offered.
Yes.
No, is still we offer. You know, practically what happens that suppose एक भी mutation नहीं आया, फिर तो baby चाहे carrier है या unaffected है.
Yes.
You know, so if you can do a proper counseling, if you can convince them that, you know, so because we have tried in the past and, you know, this has worked for some.
Okay, ma'am.
And also if they have an affected child, then you can do the linkage analysis as well.
Yes, ma'am. Yeah, if there's affected
so
sibling,
we don't deny prenatal in any case of beta thalassemia.
Okay, ma'am. Okay, ma'am.
Yeah, and for the audience, it is important that if one mutation is identified in the fetus, and then they should not continue. They should go for genetic counseling to understand the implications of whether it is minor or major, because this is a very big thing, because otherwise the child will be affected. So, you know, most of the time in thalassemia, many of the labs, they are just doing the 5 common mutation or 9 common mutations, and they are not able to find. So probably I think it's time that you rightly highlighted that we need the complete beta globin gene sequencing. And if the mutation is not identified, then of course the MLPA also. So thank you, Dr. Senthil, for your presentation. It was wonderful. So
thank you very much, ma'am, for the opportunity to the Medgenome.
So Vandana, if you want to do some make some comments here. Yeah, we can't hear you. We can't hear you.
Yeah, you have to unmute me. I'm unmuted. Dr.
Okay.
CV, I've driven from the clinic and reached home.
Yes, yes. I could see. I could see.
So
Yeah, but you utilized the time. You reached home in time. By the time we could catch you again.
I think I'm the first panelist who has driven a car and also done panel discussion.
Yes, yes. That is the beauty of webinar. It is quite flexible. The timings.
Self-driven,
Yeah, self-driven.
So I think all the points are well covered, and thalassemia being so common, one has to be very well versed with all the tests which are available. A lot of I think recently, even in the remote areas, more and more people are getting aware, and patients from even the B-tier towns are approaching us now for. So the labs which are offering should be, covering the smaller towns also.
Yes, ma'am.
Mutations.
But they should be doing comprehensive covering. Yeah.
Yes, ma'am. Yes, ma'am.
Yeah.
Because there is a lot of scope there, and then patients obviously approach us for prenatal diagnosis once the mutation testing is on time.
Correct.
It should be done in as early as possible, the prenatal period, or even in the pre-pregnancy.
10 to 15% will not be in the 5 or 9 common mutation. So that's a big chunk. 10 to 20%. So sensitivity is just 90%, 95% by these 5 common or 9 common mutations. So mutation analysis in beta thalassemia, in case one doesn't identify, then they should go for the thorough sequencing, then MLPA, and then only we can so move ahead with the prenatal. So without having the parental, and one thing also, if the child is on blood transfusion, the mutation analysis of the child may not work much. So in that situation, you should do the parental analysis only. Because these are practically important, because many a times these children are on the regular blood transfusion.
Yeah, that's one important point, ma'am. Thanks for highlighting on that.
Yeah,
also, from the med genome, I would like to include one more point. We are having these certified genetic counselors who can speak in multilingual, actually, Hindi, Kannada, Tamil, Telugu, and all kind of languages.
They can speak, but what happens? They lose the clinical input. So that becomes very theoretical, and patient gets confused. So many a times patient keep on surfing one doctor to another by till the time they reach us. So but it's always important that when there is some issue, straightforward unko de dijiye, but जिसमें थोड़ा सा भी issue है ना, better होगा कि किसी उनको मतलब ना clinical genetist से connect कीजिए, because they have just done online fellowship for 5-6 months, and how can how can they handle such a sensitive issue? So that's what my biggest concern, because the patient keeps on immediately they would write microarray, immediately they would write whole exome, and at the end of the day nothing is conclusive. So I think they should come up only when the diagnosis is made. Then that is straightforward. Recurrence risk 25%, 50%. You go for amnio, you go for CVS, like that. When the diagnosis is already made. But when the diagnosis is not made, I think they should not, enter into it, because the training is not proper in India. So
no, point very well taken, ma'am.
It's not proper. They have been, by many
clinical genetic supervision can
The thing is that their role, what we see as them, is at least to collect this family history and that pedigree chart.
Yes,
they have
to
make.
the basic
for them,
things
we are
they can
replacing.
do, but the recurrence rates, making a diagnosis, and these are important things. So I think simple, straightforward they can do, because there is not enough training. Because I have seen many of them, there is not enough training in India. Just 1 or 2 online courses, and that's all.
All right, ma'am.
And it's such a sensitive issue, and particularly the pregnancy. So it's a very, very sensitive issue.
Yes, sensitive.
So I think we should not forget the clinical geneticists, because they play a pivotal role in making the correct management.
No, very, very important, man. That's a very, very important.
So your lab is good, but it should be channeled through a proper channel. So
proper channel, man. So we have onboarded DM genetics, clinical genetics.
Yeah, they are important. You should highlight. So they should be counseling rather. All the cases when there is a some confusion in the making a diagnosis.
Dr. Seema, please allow me to say a few words.
Yeah.
My camera is switched off because this thing is on.
Himanshu? Yes, ma'am. So I'm really overwhelmed. You are here till
Yes. I am really
I have no words.
Grateful to you to AOGD, and my request again is, once again, is that please take the lead in, doing your very best, whatever is possible, so that together along with Thalassemics India and with the help of the government, we are able to do something to prevent the birth of future thalassemia children.
Yeah,
so
we would love to join. We would love to join.
Thanks a lot. And it was very informative for me also. Thanks a lot.
Thank you, ma'am. Thank you, ma'am. We would love to join. Of course, it's serving these, society as a whole. Alone we can't do. We have to move together. Yes. So I think now it's time to say a vote of thanks to everyone. So first of all, I would like to thank my chief guest, the guest of honor, the experts for the session today. Their presence made us. So Dr. Ashmita ma'am, would you like to say something? Dr. Asmita ma'am, I think she has left. So I think a very valuable contribution by the experts, by the guest of honor, by our...
Hi, Seema, I'm sorry, I'm here only. Tell me.
Hey, Asmita ma'am, you are there? Yes, you are there. So I was talking about our chief guest, Dr. Asmita. She is...
Okay.
So she wanted to, if she wants to make some comments. Then I would like to thank with core of my heart with all the faculty for the way they enthusiastically they participated. That I'm really too much impressed by everything. All the both the organizers, the Dr. Gitanjali, Dr. Bhavna, I really like their enthusiasm in making the preparations. They made my job so easier that I had to just do the real admin works this time. And I also extend my sincere thanks to all the delegates who have been, whose presence has made us more, talk about all these, that made us more to work harder like this. And also I would like to thank MedGenome. And last but not the least, my sincere thanks to Mr. Shivam. And I can vouch for him that he is the most approachable, IT person whom I have come across. He will answer your every calls at any point of time, and he will solve them also. Not only that, he answers, he works upon also all the problems. So I'm really impressed. So I think Dr. Achla has chosen a very right person for the, his this. So thank you everyone once again. So I think now we can. So Shivam.